clear? It's still little, not high. It's still little, not high. It's still little, not high. Sebelah sama Wong dia.
Mungkin Mas Rudi di musiknya diberhentikan dulu kali ya Bu ya. Kita
Ya
lagi-
coba Rudi stop musiknya biar kedengaran.
Baik Bu, baik.
Ya. Susan memang agak kecil Bu suaranya.
Kecil suaranya.
Ya.
我哋揀得啱唔啱咧？其實1、2、3、4、5、6、7、8，
Oh dia satu ruangan.
有就聽。
Kan dia satu
我
rumah
而家換
sakit.
咗去第二個咯。
呢度，咪呢個咧？
Richard, can you hear me？
Okay, good, excellent.
佢哋
Yes, I hear your Susan.
正在直播了解。識。唔係，佢有時第一個窿或者第二個窿㗎。我係咪要插翻第一個窿咧？
3 menit lagi ya Bu.
Okay. We test first, Mr. Rudy. We test about the picture, the voice. Yeah. Let me check again. How about from Mr. BC Susan? Is okay. We check first. Miss Vera, please.
Cek 1, 2, 3. Cek 1, 2, 3. Is it clear?
Yes, it's clear. It's clear for me.
Okay, thank you, Miss
How about
Hong.
Susan? Is clear, Susan? Please, your voice.
Can you hear me? Is it better?
Yes.
It's better. Yeah, I can hear.
Yes, I hear your sound, but not not so clearly. How about your Wong, Mr. Wong?
Yeah.
How about your?
Yes, it's very clear.
Yes, Mr. Wong, voice is clear and the picture is good. Yeah, it's clear too. Once again, Miss Susan, please.
Can you hear me?
Oh yeah, of course. Okay, I hear now. Yeah, it's okay. Bu Nani, Miss Vera, Mr. Rudy.
Yes. Yes, I can hear
Yes.
Okay.
Mr. and
Okay. Are you ready, Miss Susan, Mr. Wong? We will start this session. We start to opening the webinar. Okay.
Okay.
1 minute again.
Okay. Very nice to meet you here, Susan. And Mr. Wong, yeah, for the next 2023, yeah, please join with us together again.
Thank you for your
Yeah. Let's go, Miss Vera.
maybe Mr. Rudy will accept the participant before I start this
Okay.
event, ma'am.
Okay.
Ya, saya akan masukkan peserta dulu ya Bu.
Okay. Please.
Saat
You
ini
know,
baru 157 Bu ya.
you know, Miss Susan and Mr. Wong, we are participant now. more than 500 participants, around
Wow.
860.
Wow.
It's too big. Yes. And
Bu, izin saya masukkan ya.
ya,
1,
silakan.
2, 3 ya.
Please. Ya, sekali belas. Sudah masuk semua? How was Miss Tita? Very city time.
Jumlahnya luar biasa Bapak Ibu karena ada di daerah permukaan tubuh. Dan dia juga mempunyai peran yang sangat penting. Ya.
Oh, untuk sawi ya. Mohon mangga. Mangga. Mohon kalau
dulu. Mau Zoom.
Silakan Bu, Berat sudah tinggal 7 peserta lagi yang di ini.
Zoom.
Masih belum bergabung.
Bisa dimulai Pak Rudi?
Bisa Bu.
Lu tak masang wifi ya. Lu anakku enggak ya. Ayo masuk.
Mas, saya dia
Mana nih Zoom kok?
Bu Rita masih di mute Bu. Ini saya soalnya langsung all mute terus karena bocor lagi.
Iya, betul. Mas Rudi, Ibu bisa dijadikan co-host, udah dijadikan co-host, biar Ibu bantu kalau.
Tadi sudah kayak Bu.
Oh ya.
Iya.
Oke, udah.
Salam. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning, ladies and gentlemen. Om Swastiastu, Namo Buddhaya, Salam Kebajikan. Excellency, the President of Indonesian Oncology Nurses Association, Dr. Kemalarita Wahidi, SKP, Spesialis Perawatan Onkologi, ITN Mars, Visqua, respectable all the speakers, Ms. Susan Mack, RN, BHRC, MN, FHKN, UICC, Mr. Kalfai Wong, RN, BN, MSc, FHKAN, Ms. Dr. Aleni Dekania, SKP, MSc, Mr. M. Nafis, G. S. Farm, Apotheker, respectable all participants of this seminar.
Udah mulai.
Yang selalu kami banggakan seluruh peserta webinar internasional Himponi yang hadir baik melalui link Zoom ataupun YouTube. Untuk selanjutnya, saya akan menyebut seluruh peserta dengan Sobat Nurse Himponi. First of all, Let's thank the Almighty Allah Subhanahu wa Ta'ala, who has given us some mercies and blessings so that we can attend this agenda without any troubles and obstacles. Secondly, salawat and salam may Allah be given to our Prophet Muhammad Sallallahu Alaihi Wasallam, who has guided us from the darkness to the lightness. I would like to introduce myself. I'm Era Sulistianingrum, will be your master ceremony of this morning, or this morning. Baik.
Yes, webinar. This is the
Before we start this event, I will allow me to introduce you to today's agenda. First, opening is ongoing now. And then listen to the song Indonesia Raya, Mars PPNI, and Mars Himponi. Then pray. And then delivery of opening remarks and keynote speaker by the president of IONA. Then introduction to the of the moderator. Discussion first session and question and answer the first session. And then the second session, and then the last closing. Baik, memasuki acara selanjutnya adalah mendengarkan lagu Indonesia Raya dilanjutkan dengan Mars PPNI dan Mars Himponi. Kepada seluruh peserta Zoom, kami mohon dapat duduk tegak.
Diulang lagi.
Nyerinya itu 4-5. Adanya nyeri setelah digaji, mengerik referensinya 4-5.
Persatuan Perawat Nasional Indonesia, wujud ikatan profesi perawatan, tempat membina dan mengembangkan kemampuan diri dalam membuktikan keberadaannya. Menapaklah dengan keyakinan lebih pasti, sejajar dalam abdikan diri, bangkit berdiri dan langkahkan kakimu itu, menatap hari esok penuh asa. Wahai perawat Indonesia, bangkitlah dan majulah untuk menolong sekalian yang menderita. Kuatkan Kuatkanlah pribadimu, tingkatkan pengetahuan untuk memberikan asuhan keperawatan. Kita melangkah untuk mengisi pembangunan bangsa negara
memang tunggu nanti apa lama dia.
untuk mengantarkan bangsa menuju sehat semua dengan semangat jiwa Pancasila. Maju perawat, majulah dalam kancah pembangunan, tunjukkanlah pada semua orang. Jadilah perawat model kesehatan bangsa kita, jadilah teladan dalam hidup sehat. Bangkitlah perawat seluruh Indonesia dalam mengemban citra profesi, menjunjung tinggi kode etik keperawatan, laksanakan panggilan tugas mulia, mencapai derajat kesehatan seoptimal mungkin bagi warga negara Indonesia. Sebagai bukti kiprahnya mahkota putih suci dalam mendukung pembangunan kesehatan. Dengan organisasi PPNI yang kokoh, padu bersatu, serta selaras, perawat Indonesia akan mampu angkat citranya di mata insan dunia. Himpunan Perawat Onkologi Indonesia, tempat membina, mengembangkan kemampuan diri, mengemban citra profesi perawat onkologi, memberikan layanan secara holistik. Perawat Onkologi Indonesia, siapkan diri secara kompeten, komitmen ikut membangun bangsa Indonesia. Seluruh jiwa raga, perawat onkologi Indonesia, maju terus berjaya. Tangan sentuh dengan kelembutan, berikan senyuman dengan penuh kasih, memberikan layanan secara holistik. Perawat onkologi Indonesia, siapkan diri secara kompeten, komitmen, confident, compassion, etik, ikut membangun bangsa Indonesia, capai derajat kesehatan optimal, baktikan seluruh jiwa raga, perawat onkologi Indonesia, maju terus berjaya, maju terus berjaya.
Okay, thank you. Sobat Nurse Himponi yang kami banggakan, so that this event can take place well and according to plan, let's pray. Prayer will be led by Nurse Rudy, Sarjana Keperawatan. To Mr. Rudy, please join in room.
Baik. Apakah suara saya terdengar, Bu?
Ya.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi taala wabarakatuh.
Waalaikumsalam.
Good morning. Thank you for the time. Let's pray before we start our webinar. Let me lead the prayer for the Muslim participants, and non-Muslim participants are welcome to pray according to their religion and belief. Pada kesempatan yang baik ini, izinkan saya untuk memimpin doa di pagi hari ini. Semoga saja acara berjalan lancar. Bagi yang Muslim, insya Allah akan saya pimpin. Dan kepada peserta yang non-Muslim dipersilakan untuk berdoa menurut agama dan kepercayaannya masing-masing. A'udzubillahi minasyaitonirrajim. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin, hamdan syakirin, hamdan na'imin, hamdan yuwafi ni'mah wa yukafihu majidah. Ya Rabbana lakal hamdu kama yanbaghi li jalali wajhikal karim wa 'azimi sultanik. Allahumma shalli wa sallim ala sayyidina Muhammadin wa ala ali sayyidina Muhammad. Allahumma ighfir lana dzunubana li wali walidina warhamna warhamhum kama rabbayana shighara. Wa li jami'il muslimina wal muslimat wal mu'minin wal mu'minat al ahya'i minhum wal amwat innaka ala kulli syai'in qadir. Allahumma inna nas'aluka ilman nafi'an wa rizqan halalan thayyiban wa mu'amalan mutaqabbalan. Ya Allah, ya Tuhan kami yang Maha Pengasih lagi Maha Penyayang, sayangilah kami dan kedua orang tua kami sebagaimana mereka menyayangi kami dari sejak kecil. Ya Allah, ya Tuhan kami yang Maha Pemaaf, maafkanlah kami dari semua kehilapan, baik yang disengaja atau yang tidak disengaja. Ya Allah, ya Tuhan kami yang Maha Mengetahui, berikanlah kami ilmu yang bermanfaat. Jadikanlah ilmu yang disampaikan di kegiatan pagi ini menjadi ilmu yang bermanfaat bagi pasien dan tenaga medis. Ya Allah, ya Rob yang Maha Kaya, berikanlah kami rezeki yang halal, baik dan berkah. Ya Allah, ya Rob, berikanlah keselamatan pada kami semua agar acara webinar pada pagi hari ini berjalan lancar dan aman. Rabbana la tujigh qulubana wa'adait hadait lana wa hab lana min ladunka rahmatan innaka antal wahhab. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Wa sallallahu ala sayyidina Muhammadin nabil ummi wa ala alihi wa sahbihi ajmain. Bifalika subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahi rabbil alamin. Demikian doa yang disampaikan, mudah-mudahan diijabah oleh Allah Subhanahu wa taala. Dari saya cukup sekian, terima kasih. Thank you very much. Assalamualaikum warahmatullahi taala wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Amin amin ya robbal alamin. Semoga Allah Subhanahu wa taala mengijabah doa kita hari ini agar dimudahkan dan dilancarkan kegiatan kita sampai akhir. Okay, next agenda will be a welcoming speech. Allow us to invite Mrs. Dr. Kamalarita Wahidi, SKP, Spesialis Keperawatan Onkologi ITN Mars, Fiskwa. To Miss Kamalarita, please come in, join in room.
Ya. Terima kasih. Thank you very much, Miss Vera, for this time. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera bagi kita semua. Om Swastiastu, Namo Buddhaya, salam kebajikan. Good morning to all participants. Puji syukur kita haturkan kepada Allah Subhanahu wa taala, berkat karunia dan izinnya kita semua bisa berkumpul di ruang Zoom pada pagi yang cerah hari ini. On behalf of the Executive of Board of Indonesian Oncology Nurses Association, I would like to welcome you all in this international webinar of promoting patient safety in oncology nursing practice. It is an honor for me for being here with you all webinar participants from overseas and from Indonesia. In this opportunity, I would like to express my appreciation to all speakers. First, Ms. Susan, MEK, RN, BHSC, MN, FHKEN, Clinical Oncology Nurse Consultant. And Mr. Wongke Fai, MSc, BN, RN, EPN, FHKEN, from Prince of Wales Hospital, Hong Kong. Thank you very much for you both for your time and your willingness to share your knowledge, experiences, and your expertise in patient and staff safety in radiation and chemotherapy modality. Dr. Aleni Dekania, SKP MSc from Faculty of Nursing, University of Indonesia, thank you for your time to share your experience in pediatric oncology nursing safety. To Mr. Nafis Gozali, S. Pharma, APT, thank you for your time to join and support this event. To Bibron Medical Indonesia team, who generously help us make this international webinar come true. Mr. Nafis Gozali and Mr. Adi Utomo and team, thank you very much for your good cooperation with us. Ladies and gentlemen, the international webinar participant, IONA is Oncology Nurse Association in Indonesia, which units the nurses caring for cancer in all Indonesian region. As a nurse association in oncology nursing, we strive to update the oncology nurse competency so the education, training, webinar like this in COVID-19 pandemic era to maintain our knowledge and to give better insight and understanding in dealing with cancer patients along the continuum of care. To uplift the spirit for you all, let me share with you one slide about the role of oncology nurse in cancer care continuum, and it is related to with this morning webinar topic. Let me share one slide for you all. Oke. Bapak, Ibu, teman-teman semuanya, sahabat Himponi ya kata Mbak Vera tadi ya. Ibu hanya ingin menjelaskan saja bahwa di dalam hal ini peran kita di dalam continuum care of cancer ini sangat panjang sekali, mulai dari health promotion, prevention, ya di dalam hal ini terkait dengan edukasi, terkait diet, olahraga, exposure alkohol, pencegahan terhadap penggunaan tobacco, dan lifestyle. Ini adalah peran kita pada health promotion. Jadi perawat kanker rentang perannya sangat panjang sekali Bapak Ibu teman-teman semua, dan juga pada early deteksi, deteksi dini. Bagaimana perawat bisa melakukan screening, ya bisa melakukan pemeriksaan IVA test, bisa memberikan edukasi dan seterusnya, dan juga bisa mengontrol gejala-gejala sedini mungkin. Selanjutnya perawat juga berperan pada fase diagnosis, ya baik itu pada waktu melakukan biopsi, melakukan tumor staging, bagaimana perawat mendampingi pasien, memberikan konseling sehingga pasien dapat membuat suatu keputusan, dan juga tentunya memberikan informasi terkait dengan informed consent. Dan yang keempat, peran kita ada pada fase treatment.
Sayang kenapa saya ngantuk ya?
Pada fase treatment ini terkait dengan kemoterapi dan radiasi yang pagi ini kita bicarakan topiknya, dan juga surgery, symptom management, dan aspek psikososio spiritual dan culture pada pasien kanker, serta supportive terapi atau maintenance terapi. Jadi peran kita sangat banyak sekali teman-teman. Selanjutnya ada lagi peran kita nih pada fase survivorship. Bagaimana long term follow up surveillance kita bisa lakukan, bagaimana kita bisa memanage late effect, efek lanjut daripada tindakan modalitas terapi, baik itu kemo maupun radiasi, dan juga penguatan coping daripada pasien. dan terakhir peran kita ada palliative care, ya, dan juga pada kondisi end of life care, ujung akhir kehidupan, bagaimana kita memberikan support kepada pasien dan keluarga, baik terkait aspek fisik, psiko, sosio, spiritual, dan kita membantu keluarga untuk membuat keputusan yang terbaik pada fase-fase ini. Bapak Ibu sekalian, semua fase ini memerlukan satu kompetensi khusus yang tentunya perlu Bapak Ibu semua untuk dibekali dengan berbagai ilmu. Jadi untuk ini adalah sekedar trigger bagi teman-teman sahabat Himponi semuanya, bahwa masih banyak yang perlu kita kembangkan di area layanan kanker ini. Dan mudah-mudahan semua ini bisa meningkatkan kompetensi kita secara perlahan, dan pada ujung akhirnya yang kita inginkan adalah peningkatan kualitas asuhan kita pada pasien-pasien kanker tentunya. Bapak Ibu sekalian, ya, today's the international webinar will give you, ya, the opportunity to discuss deeply about patient and safety in oncology nursing, because some of cancer modality therapy, like chemotherapy and radiation therapy,
Suara Bu Rita.
ya. Sorry, ya. Today, the international webinar will give you opportunity to discuss deeply about patient and safety in oncology nursing, because some of cancer modality therapy, like chemotherapy and radiation therapy, has a side effect to the staff and to the patients. I hope everyone can get benefits from this webinar to the interesting topic, and also by the end of the webinar, everyone will have a better understanding in dealing with patient and staff safety. And more importantly, we hope this webinar can help ourselves grow up professionally. Congratulations and congratulations on joining this webinar. Stay healthy, stay enthusiastic, and stay safe. Mudah-mudahan webinar yang kita laksanakan pada hari ini bermanfaat dalam meningkatkan kualitas asuhan kita pada pasien kanker. Demikian sambutan saya. Terima kasih banyak atas perhatian dan kesempatannya. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih kepada Ibu Kepala Rita yang sudah menyampaikan sambutannya. Semoga apa yang telah beliau sampaikan tadi dapat selalu memotivasi kita semua untuk terus meningkatkan dan mengembangkan diri secara keilmuan dan juga kompetensi, khususnya di bidang onkologi tentunya. Seperti kegiatan hari ini yang bertujuan untuk memberikan update ilmu pengetahuan tentang keselamatan pasien dalam praktek keperawatan onkologi, termasuk saat pemberian kemoterapi, radioterapi, dan juga pada keperawatan onkologi anak. Baiklah, Sobat Nurse Himponi yang sudah bergabung, pastinya sudah tidak sabar untuk mengikuti acara webinar internasional hari ini. Selanjutnya, kegiatan ilmiah kali ini, Himponi bekerja sama dengan PT B. Braun. Ini merupakan webinar internasional yang kedua, di mana kali ini kami mengundang dua pemateri yang berasal dari Hong Kong, yang pastinya sudah sangat expert di bidangnya, yaitu dalam patient safety dalam pemberian kemoterapi dan juga radioterapi. Sebelum saya serahkan ke moderator, izinkan saya membacakan tata tertib webinar pada hari ini. Untuk tata tertib acara webinar akan ditampilkan oleh Bapak Rudi. Ya, jadi tata tertib acara Zoominar hari ini yaitu seluruh peserta sudah hadir dan juga login melalui Zoom, link Zoom yang sudah diberikan oleh panitia. Kemudian seluruh peserta dimohon untuk menyalakan videonya selama aktivitas webinar ini berlangsung dan juga mematikan suaranya kecuali pada saat dimohon untuk seluruh peserta untuk mematikan suaranya kecuali pada saat sesi tanya jawab. Kemudian yakinkan kuota dan koneksi sinyalnya kuat untuk dapat mengikuti secara fokus dan lancar. Baik, selanjutnya untuk seluruh peserta dapat menggunakan nama asli dan juga yakinkan tidak ada kesalahan pada saat input data saat registrasi nanti. Untuk link absen akan di-share pada sesi tanya jawab dan juga akhir acara, sehingga pastikan seluruh peserta mengikuti seluruh kegiatan acara. Dan untuk panitia juga peserta diharapkan menggunakan virtual background yang sudah di-share, namun jika tidak memungkinkan tidak wajib. Baik, selanjutnya, pada sesi pertama ini akan dipandu oleh moderator kita yang juga expert. Beliau adalah Nurse Ariesta Milanti, Sarjana Keperawatan MHC. Sebelum beliau memandu diskusi sesi 1, izinkan saya membacakan kurikulum vitae beliau. Nama lengkap beliau adalah Ariesta Milanti binti Endang. Beliau lahir di Jakarta pada tanggal 15 April 1986. Beliau tinggal di Jalan Galur, Sari Timur, Utankayu, Selatan, Jakarta. Saat ini beliau adalah seorang mahasiswi PhD di The Northern Seoul School of Nursing, Chinese University of Hong Kong. Beliau juga tergabung di Himponi dan juga mempunyai berbagai macam penghargaan. Beliau juga menjadi seorang penulis dan sudah mempublikasikan tulisannya yang terakhir yaitu yang berjudul Deficient Healthcare Service as Barrier to Meet Care Needs of Gynecological Cancer Survivor in Indonesia. Selain itu, beliau juga sudah sering menjadi pemateri di beberapa event nasional dan juga internasional. Selain di Himponi, beliau juga tergabung di INSCC dan juga American Society of Clinical Oncology. Baiklah, tanpa memanjangkan waktu, kami panggil Ibu Nurse Ariesta Milanti, Sarjana Keperawatan MIC, untuk memandu diskusi sesi 1 ini. Okay, please join in, Miss Ariesta.
Thank you very much for your kind introduction.
Time for you.
Baik, terima kasih Nurse Vera atas introduction-nya. Thank you very much for your kind introduction. Now I would like to introduce our first speaker for today, Miss Susan Mack, RN BSHC MN FHKN. And before we start, I would like to read some of her curriculum vitae. I would like to highlight some of her curriculum vitae, so please preview the curriculum vitae. So Ms. Suzanne is a nurse consultant of clinical oncology in New Territories East Cluster in Hospital Authority in Hong Kong and she obtained her Bachelor of Health Science from the University of Western Sydney, Australia, and her Master of Nursing from the Chinese University of Hong Kong in Hong Kong, China. She is a fellow of Hong Kong Academy of Nursing and a fellow of the UICC, the Union of International Cancer Control, and she has received plenty of awards and scholarships related with many areas in oncology nursing. And Ms. Suzanne has extensive professional experiences, research experiences, and numerous publications. And we are so happy to have Ms. Suzanne here to share with us her expertise and experiences. So this is her curriculum vitae, which is very impressive, very long and outstanding. So we can see her many awards and scholarships that she received, her fellowship, her professional licenses and certifications, and also her professional experiences and research experiences and also publications. So we will have 30 minutes presentation from Ms. Suzanne today. And her topic today is promoting patient safety in chemotherapy for patients and providers from preparation to patient discharge. Thank you very much, Pak Rudi, for your preview. So I would like to welcome Ms. Suzanne. Without further ado, please welcome Ms. Suzanne Mack. Over to you, Ms. Suzanne.
Thanks, Arista. Long time no see. Can you hear me?
Yes, we can hear you clearly.
Arista, nice introduction, and I'm very glad to receive a sincere invitation from Indonesian Oncology Nurse Association and Dr. Camilla Ritter for your sincere invitation. And I'm very honored to I can participate in this international webinar, which is a very meaningful event. Yes, I'm very glad I can join. And Arista, I can share my
You can share your screen.
Yeah. Can you see the PowerPoint?
Yeah, we can see your PowerPoint.
Yes. The topic I'm going to present today is promoting safety in chemotherapy. Our mission, Indonesia Oncology Nurse Association, give me the mission is in the two aspects. Focus on the two aspects for patients and provider, from preparation to patient discharge. Because today's the time is 30 minutes, so I won't take it long because the topic is very broad.
Excuse me, Ms. Suzanne, could you please make it full view?
Yes, we are now to make it full.
Now it's still in presentation view.
Atau dari kita, Mbak Tita, atau dari kita?
Kayaknya dari sana deh, Bu.
Bukan maksud Ibu, atau kita yang nampilin, dia mungkin kagum.
Oh, or would you like us to share your PowerPoint from here?
Can share your.
Halo? Oh, Ibu. Iya, kan 2 kali tuh. Tanggal 8 malah baru demo. Pastinya. Kenapa?
Ariska, are you
Yes.
share your
Oh yeah. Pak Rudi, would you please help us? Pak Rudi bisa tolong dibantu share screen PowerPoint-nya Bu Susan?
Ditutup dulu.
PDFs, not
PDF ya?
Yes.
Oh, okay. So the PowerPoint that we have is the PDF version. So probably
PDF is also okay. Cannot make
Bisa ditampilin.
at my site because the full screen cannot make.
All right.
Dia bisa besarkan, tak?
If in the PowerPoint, is it acceptable?
I think it's acceptable actually. We can see it. If the font size is quite big, we still can see it.
Yeah, okay. Then I continue. Okay. As I just mentioned, there are when talking about the safety in chemotherapy, there are 4 aspects we should notice. Because the time is not long today, so I will elaborate the major points under each aspect of this. Then come to the first aspect, the safety during patients' cancer treatment journey. I try to use a patient's cancer treatment care pathway to help elaborate how the patient safety, how the safety of people we should pay attention during all the throughout the journey. The first step, access when the patient access and to the oncology center, or there is a referral to an oncology center, then the oncology providers should establish a pathway to ensure rapid and appropriate management of the patients presenting with previously undiagnosed cancer. And we also have the major role in effective management of patients admitted with complications during the course of chemo. And at step 2, when the patients come to the oncology center, the doctors will see the patients and decide what treatment the patients should receive. So at this moment, then the decisions about the treatment will be made by the consultant or the specialist. Then a standardized consent form should be made.
Excuse me, Ms. Suzanne, the slide has not changed yet. Yeah, so this one, we didn't see your slide changing before. Now it's okay. Probably
okay,
you can continue to the next slide.
Yeah, we are making it. 係啦，呢個 file。咁我先開咗佢。唔係後邊呢個。咪但係去唔到喎。
All right, now I think we can see it this way.
Is it okay? Okay.
Yeah.
Then the step,
Now it's moving.
the step one, you can here you can see the patient's access and get referred to an oncology center. And step two, the assessment and decision to treat and provide intervention. As I just mentioned, when the decision is made, a standardized consent form should be ready, and they should include the details of participant and with written information, and a copy of the consent box should be given to the patient, as well as being filed in the patient's case record. All patients should have a signed treatment plan for each line of chemotherapy they undergo. The treatment plan basically should include the following information: the diagnosis, staging, performance status, and comorbidities. The treatment intent is palliative or curative, which should indicate in the patient's treatment plan. And the tests required for the chemotherapy, like hepatitis test. You may know if the patients have hepatitis, then which is a very high risk factor for the patients who will develop the complications after receiving chemotherapy. So we should make the p-test to know whether the patients have suffered from any hepatitis positive disease. And step 3 is prescribing and dispensing. Protocols agree across an institution, and up-to-date list of protocols should be available in our institution. And records should be kept when patients' treatment has been off. And they should be by a handwritten or electronic prescribing system is also okay. Depend on the development of your countries, whether the electronic prescribing system is already developed. A list of clinical staff designated to prescribe, check, or dispense or and administer chemotherapy should be maintained and updated. And the standardized process for recording the performance status, investigation result, and serious toxicity should also be ready. I just mentioned the chemotherapy administration is important. So the nurse training, a standardized and structured training for chemotherapy nurse should be available to support the nursing workforce. In Hong Kong, we have our standardized chemotherapy nurse training. The nurse who administer the chemo, or the bonus, they should have received the nurse training, the training for the chemotherapy nurse.
Bisa bahasa Inggris.
And for those who perform the chemotherapy administration, we perform the regular training and briefing to remind all nurses who give the chemotherapy administration. And for the step 4 and 7, delivering treatment and intervention, the providers of oncology service should undertake rigorous and ongoing capacity planning. The main goal is to reduce the patient's delay and improve patient experience, less congestion in the center, smoother workflow, effective planning and introduction of new drugs, tighter compliance with the regimen protocols, enhanced communication, better management of resource, and establish good practice. We should streamline the care to minimize inconvenience. The capacity and demand at different times of day should be carefully examined to make best use of the available resources. Here you can see this the day ward of our center. We have the day chair and day bed for the ill patients and or the prolonged infusion. And we also strengthen our nurse competence in chemotherapy and RT service with upgraded working protocol to increase their capacity and flexibility to reduce the patient's waiting times. Our chemotherapy nurse will perform the intravenous bonus of chemotherapy administration, and they will do the proper documentation of the patient progress after the patient's consultation. And our nurse also, we have the nurse clinic. We will perform the assessment and support to the patients during their chemotherapy or radiation therapy. Basically, inpatient delivery of oncology service, we are not so encouraged because of limitation of our inpatient beds. So it should be kept to a minimum. In another way, we try to maximize the use of oral medicines. As you know, there are some oral chemotherapy have been developed, such as the capecitabine or some other new drugs. And we also use the central lines, such as PIC9 or Hickman-9, to deliver the prolonged infusions. Then the patients can go back to home with the central lines. And use of the day beds to deliver the more prolonged infusions is very common practice in Hong Kong. And for the written information, we developed some written information to patients about the treatment and the likely side effects, and delivery of such information should be documented. We conduct face-to-face education to the patients at start of the program or at imminent administration of the chemotherapy. And step 5, the patient and carer information support and advice is very important. We'll provide each patient with a card containing key information about the treatment and contact details. And telephone advice service is not so common in Hong Kong yet, but we in the future we will develop more at this side. And we also established proactive targeted support service to pick up the problems before it becomes serious. Step 6, urgent assessment and management of complications. We empower our nurses working in oncology center to handle the patients who may develop the complications. And also we develop the close links with all neighboring hospitals with A&E departments. When the patients develop the emergency such as neutropenic sepsis, then we will alert the patients to come back if they develop the fever. We ask the patients to come back to the A&E, the emergency departments, for the appropriate treatment. We ensure the antibiotics can be given to the patients within 1 hour. We measure the door-to-needle time regularly to audit our service whether it is up to standard. Step 8, end of treatment. After completion of the chemotherapy, we will have a summary record and care plan A care plan should be drawn for each patient after completion of the treatment. Then come to the second aspect, safety in management of systemic anti-cancer therapy. I think all the oncology nurses should keep in mind the difference between chemotherapy, targeted therapy, and immunotherapy. They have different characteristics. For chemotherapy, they have the side effects which are so different from targeted therapy and immunotherapy. And for immunotherapy, because it's still very expensive, but the effect is the side effect is less, relatively less than chemotherapy and targeted therapy. But because it's still very new, the long-term effects mainly focused on the autoimmune effects is still under a lot of study to prove. Okay, for chemotherapy, the nurse should bear in mind these terms. What is primary? What means by adjuvant? What means by neoadjuvant? And the cytotoxic drug selection. What is the reason behind the cytotoxic drug selection and chemotherapy drug resistance, and why we use the combination of chemotherapy. Here is an example. Because time is very short, so I just show an example about the colorectal cancer. Here you can see for this disease, a lot of cytotoxic drugs can be used, or some targeted therapy can be used to treat the colorectal cancer. Here you can see for stage 3 colorectal cancer, the 5-FU leucovorin for 6 cycles can be used, or capecitabine for 8 cycles can be used, or FOLFOX, the ambulatory chemo, including a combination of 5-FU, oxaliplatin, and leucovorin are delivered by the ambulatory pump, can be given to the patient. There are different choices. Some patients may be given for the irinotecan, the late stage of cancer may be given with the irinotecan. There are many different side effects for different drugs. So the oncology nurse need to know the different characteristics of different drugs. Chemotherapy administration, when we're talking about this practice, we should bear in mind about the qualifications, training, and standard. How to handling the hazardous drugs, patient and family education, and safe practice considerations. For our chemotherapy nurse would regular to perform the chemotherapy patient assessment for each patient who come to receive the chemotherapy administration in our day center. Our nurse, when they come to receive the training, we will have all the chemotherapy nurse learn to how to calculate the dose, the required dose for each regimen, and the risk of administration. And they need to learn about the vascular access device, how to handle and manipulate the device. And they also need to learn the prevention and identification management of extravasation. This is the extravasation. The patients, for this case, is extravasate with irritant. The drugs is just cause some redness or some tingling sensation in the patients, but do not cause a long-term consequence. But this case is very severe. The patient is extravasate with a drug called Vesicant. is usually the doxorubicin. As you know, the doxorubicin is commonly used in different disease. The most common one is the breast cancer disease. Is included in the regimen of AC, the AC regimen. Doxorubicin is used here. Is a very serious vesicant when the patient, when the drug leak out from the blood vessel, it will cause some burning and tissue necrosis. So bear in mind, I always alert the chemotherapy nurse, please be careful when they give the doxorubicin to the patients, and bear in mind to choose the wing, because this case needs to debline the surgical debridement and skin flap to cover it, but it affects the patient's mobility afterwards. Extravasation, the precaution is critical, so we bear in mind to choose a wing. The risk factor is the small and fragile wings we should avoid, and some sites of like the wrist here is very sensitive and very a lot of nerve and blood vessels here, so avoid the site like wrist. And the procedure, we should stop when the vesicant happened, stop the administration and disconnect the IV tubing immediately. And if there is antidote, we should consult and discuss with the physicians to whether we use it. And we better circle the affected area and instruct the patients to rest and elevate the site for 48 hours and evaluate the extent of the extravasation and tissue damage every day. Flare reaction. Flare reaction is distinguishable from extravasation. It's two different reactions. But some nurses, they may confuse with flare reaction is the extravasation. It's two different. It is very different. A flare reaction is mainly due to some allergy, but the patients may appear some swelling. The patients may appear some redness on the drip sites. But if there is lack of pain or any swelling, then and also the blood return is good, then it may mean this is flare reaction, not extravasation. Then we can flush the wound slowly with saline and watch for any the flare will disappear. If it disappears, then it tell you it's a allergic reaction. So you can talk to the physician to administer hydrocortisone to this case. Hypersensitivity and anaphylaxis. When the patient they are given chemotherapy, then they develop some uneasiness or agitation or shortness of breath. Then you have to diagnose this case as he or she suffer from hypersensitivity. You should stop the infusion, the chemotherapy infusion, and lie down the case. If the BP drop, then the patient is suspected to entry to the anaphylaxis. Anaphylaxis is very severe. We should stop the chemo infusion immediately and maintain the IV line. Keep monitoring and make the patient in supine position, monitor the vital sign, maintain airway, assess the patient for any increasing edema of respiratory tract, and administer oxygen. If necessary, we need to start the CPR and give the adrenaline and emotional support. Most of the time, if we give adrenaline to the case, then the case can recover. The toxicity and management, grading and toxicity, patient education, self-care is very important. So we should make grading to the patient toxicity and educate the patient how to take care themselves when their neutrophil is very low, or their platelets is not enough. Then we should educate the patients to avoid suppository or rectal to avoid the hard toothbrush, to avoid the constipation that may cause the patient bleeding. Some systemic toxicities like bone marrow suppression, GI tract, the skin toxicity may be developed. For the Hanford syndrome, it's very common when the patient is taking the Xeloda drugs. Hanford syndrome is very common side effects. So we need to educate the patient how to keep the skin educate the patient to use the skin lubricants to lubricating the skin and avoid dryness, etc.
Excuse me, Ms. Suzanne, you have 4 minutes to go. Thank you.
Oh, okay. And here is the toxicity and management we should bear in mind. And here is the mucositis. For this case is the candidiasis, some whitish, cheese-like whitish spots on the tongue. So many cases, they receive the concurrent chemo radiation for the head and neck cancers. It is very common side effects. We should give the gargle to the patients and educate them how to rinse their mouth. The third aspect, safety mechanism in chemo treatment. Here is the prescription process. We should bear in mind how to verify the chemo protocol and the medication administration records should be verified by the trained nurses and pharmacists. Here is the prepinned chemotherapy protocol. I think in Indonesia, you probably should have this. This would guide the doctors and the nurses to make the information fill in the form. We should have the prepinned protocol to make sure everything can be checked again. Like the body weight, body height, the body surface area, frequency, and I just mentioned the hepatitis status, pregnancy status, the contraceptive advice have you given to the patients, and consent, whether you consent, and the drug we should come with the milligram per meter square. So the chemotherapy nurse can calculate according to the information in the chemotherapy protocol. This is the chemotherapy protocol again. This is the chemotherapy medication administration record. For each case, they come to receive the treatment. We should have the chemotherapy administration record checking against with the chemotherapy protocol. Okay, so this is the standard practice. In Hong Kong, I have our guidelines ourselves to ensure each of our oncology nurses, they know how to check the drugs before they give the drugs. There are 3 checks and 5 reps procedure for the cytotoxic chemotherapy drug administration. We have 2 they check against with each other, and they need to check the chemotherapy administration record against with the chemotherapy protocol and against with the drugs and against with the patient's information. Okay, come to the last one, occupational safety. Because cytotoxic drug is the hazardous drugs, so we should bear in mind that for the hazardous drugs, there are 4 impacts on the genital toxicity, carcinogenicity, teratogenicity, and fertility impairment. So there are some potential points of exposure: drug preparation, transportation, administration, disposal, and patient's excreta, spillage. So there are risks of exposure: inhalation, direct contact, injection, accidental needle sticks. So this safe handling practice, if are not allowed, followed or fail, then we come to the risk. And the risk is highest among the pharmacists mixing the chemotherapy agents and the nurses administering chemotherapy. There are some consensus of studies. Chronic low-level exposure can lead to absorption of anti-neoplastic drugs. Use of the PPE, personal protective equipment, can reduce the absorption of the anti-neoplastic drugs. Implementation of PPE and safe handling measures can reduce the incidence of the adverse health effects. The PPE include gloves, gown, respiratory mask, face shield, goggle. The gloves, there are already some gloves are labeled with the chemo used label. So you can procure with the gloves that is labeled with this data. And the gloves should be latex in the nature, and thicker gloves less permeable, long enough to cover the gown cuff, and double gloving for drug preparation. Change gloves every hour. For the gown, during preparation and administration, we should use this disposable, single-use, lint-free, no permeability, solid fronts, and elastic cups. Eyes and facial protection, such as the goggles and the surgical masks, do not provide respiratory protection. So when we clear the leakage, for example, if the staff has got the drug overspill, then we should wear the respiratory mask to clear the leakage. Here is the PPE. And we better use the device with lunar lock fittings, so the syringe will not slip out. And prime the IV set with paint solutions first, and inspect the delivery bag prior to handling, hand washing. Because the patient's excreta will contain the cytotoxic metabolites. So we should have the standard precaution within 48 hours after administration. We should ask the patients to flush the toilet, double flushing, to perform double flushing within 48 hours after they receive chemo. And in Hong Kong and many overseas institutions, there is still the biologic monitoring is not common. It's not widely used, because it has its limitation. So in Hong Kong, we have no such practice yet, because there is some limitation to detect. So I end my presentation here. Thank you, everybody, for your attention. Thank you.
Thank you very much, Mrs. Zhang, for your comprehensive and wonderful presentation. And for the participants, we have got three questions already, but we will have question and answers later after Mr. Gavin's presentation. So it will be around 10:40 Indonesia time. So we will compile the questions and then we will ask Mr. Wong and also Mrs. Susan after the session. After the presentation. Alright. Jadi untuk peserta pertanyaan bisa ditulis di chat. Nanti akan ada sesi tanya jawab setelah presentasi setelah yang ini Mr. Wong. Jadi sekarang saya akan perkenalkan dulu Mr. Wong, pembicara kita berikutnya. Now I would like to introduce our second speaker, Mr. Ka Fai Wong, or we can call him Mr. Gavin Wong. So Mr. Wong is here with us today.
Yes, hello.
I would like to highlight some of his CV. So please, Pak Rudi, to preview his CV to us. So Mr. Wong is an advanced practice nurse in oncology nursing and deputy ward manager in Department of Clinical Oncology, Prince of Wales Hospital in Hong Kong. He obtained his Bachelor of Nursing in the Royal Melbourne Institute of Technology, Australia, Diploma in Epidemiology and Applied Statistics from the Chinese University of Hong Kong, and Master of Science Nursing Studies in Oxford University in United Kingdom. Peserta mohon dimatikan mute-nya, mic-nya. And Mr. Wong is also a fellow of the Hong Kong Academy of Nursing, and he has attended many specialty trainings and courses, including the Oncology Nursing Society, radiation therapy and chemotherapy and biotherapy in the United States. So probably we can scroll down the CV. Mungkin bisa di-scroll CV-nya. So Mr. Wong has shown lots of his expertise in the CV. Thank you very much. So Mr. Wong's topic today is promoting safety in radiotherapy for patients and provider from preparation to patient discharge. Jadi Mr. Wong ini adalah advanced practice nurse di ruang oncology nursing dan merupakan manajer di Department of Clinical Oncology di Prince of Wales Hospital di Hong Kong. Mr. Wong ini sebelumnya mendapatkan gelar sarjananya di Australia dan diploma in Epidemiology and Applied Statistics dari Hong Kong dan mastersnya di Inggris. Jadi topik Mr. Wong hari ini adalah setelah tadi kita dengarkan dari Ms. Susan tentang patient safety in chemotherapy, sekarang dengan Mr. Wong kita akan memberikan topik tentang radioterapi, patient safety in radiotherapy. And again for the participant, dan lagi untuk partisipan, pertanyaan nanti bisa diberikan di chat box atau bisa raise hand nanti setelah berakhir sesi ini kita akan mengadakan sesi tanya jawab. All right, thank you very much. So without further ado, let me welcome Mr. Wong. Please, Mr. Wong, over to you.
Hey, hello.
Hello.
Let me share the PowerPoint first. Can you see the file?
Yes, we can.
Okay. Hi, good morning. Selamat pagi, selamat pagi.
Morning, selamat pagi.
Thank you very much for the invitation. Today, I would like to share the topic of radiation safety related to the patient and healthcare providers. But what is radiation? Can it be seen? Can it be smelled? Or can it be heard? Radiation is everywhere in the universe. Since the inception of time, life on Earth have been exposed to radiation in the natural environment. It travels in the forms of waves or particles and is part of our everyday environment. People are exposed to the radiation from cosmic rays as well as to the radioactive materials found in the soil, water, food, air, and also inside our body. Before our further discussion, we need to have some basic knowledge in the physics, which is mainly related to the atom. All matters are made up of tiny units called atoms. Every atom has a nucleus, which is surrounded by a cloud of electrons. You can see an electron. And also the nucleus consists of an uncharged neutron and positively charged protons. Nucleus of most atoms are very stable. But in some cases, such as the large atoms, they are very unstable. This unstable nucleus may release particles or electromagnetic waves and spontaneously to return to their stable states. And this process we call the decay. The unstable nuclei are said to be radioactive and called radionuclides. The released particles and electromagnetic waves are called radiation. Radiation embeds the electromagnetic waves, such as the light and radio waves that we can see, and also ultrasound and particles. The particles may be alpha particles or beta particles. They are emitted by radioactive materials as they decay. Radiation cannot be heard, seen, smelled, nor tasted. Most of it cannot be felt. However, with the use of a special instrument, it can be detected and measured. It can penetrate our human body if the energy is sufficiently high, like the X-ray or gamma wave in the linear accelerator. You can see that this is the common source of radiation, such as we can see that this comes from food or drinks, cosmic rays, and also it consists about 80%. And it is the radiation level in our daily life. So for example, this one shows the equivalent years of electro background radiation. For example, if you perform or you had done a body CT scan, full body CT scan, you will receive approximately about 3 years of radiation that you receive when compared with the natural environment you live. Radiation therapy, or we call radiotherapy, plays an important role in the cancer treatment. About 50% of the cancer patients receive radiotherapy in their curative, adjuvant, or palliative setting. Incidents will also be involved by overexposure, which includes both patients and also our healthcare professionals. But in what situation will patients and healthcare providers exposed to the radiation in medical setting? There are several sources of medical exposure to radiation in hospital, such as the number one is the X-ray, radionuclides, the therapeutic use of ionization radiation, and also the linear machine. This is the working place with ionization radiation. I just mentioned the LINET, the linear accelerator, treatment room, the CT simulator, the afterloading brachytherapy suite, etc. For the patient, there are commonly 3 types of radiation therapy that they will receive. The first one is the teletherapy, we call the external radiation. And the second one is the brachytherapy, we call the internal radiation. And the third one is therapeutic nuclear medicine. Before we further going on the safety issue, we really have some basic understanding of what is ionization radiation. It includes 2 types. The first one is the particulate radiation, and the second one is electromagnetic radiation. Particulate radiation consists of atomic or subatomic particles, such as electrons, protons, which carry the energy in the form of kinetic energy or mass in motion. And also the electromagnetic radiation, in which the energy is carried by oscillating electrical and magnetic fields. It's traveling through the space at the speed of the light, such as the X-ray or gamma waves. Where is the source? Usually it comes from 2. The first one is the IA, we call IA, irradiating apparatus. Usually it's the radiotherapy machine or imaging machine or CT machine. It can produce the X-ray or electron beam. And the second one is the radioactive substance. We call the RA. We can, maybe it is alpha particle or beta particle or even gamma radiation. But what is the penetration level of different energy? The penetration level is different in view of the different energy of the radiation. For example, the alpha or beta, it can penetrate approximately up to 5 cm depth. It is suitable for the superficial treatment. And also the gamma or neutron, it can penetrate more deeper through our tissues. It may be used independently or concurrently with electrons. Due to this reason, it is a risk if we overexposure to the ionizing radiation. It will affect our health in certain level if not properly managed. What will be happen when human exposed in ionizing radiation, like the nuclear incident in the world? If in a very initial phase, the common is nausea and vomiting immediately following the incident. But later on, it will further develop more severe syndromes like cerebral CVS syndrome. It will be fatal within 24 to 48 hours. When ionization radiation interacts with our body cell, ionization and excitation are produced. It will affect our DNA of the cell, It can further alter our DNA structure and cause mutation. If only a single strand, I think all of us remember our DNA have 2 strands. If only a single strand DNA break, it can be repaired later. If both DNA, the double strand DNA, are break down, it will cause cell death, mutation, or carcinogenesis. But all our concern is that any radiation outside our working area, is any radiation outside the linear, is it safe to us? You can see that basically the wall of the linear machine of the bunker are lined with the lead lining. It is a lead, it's a metal, which the radiation cannot spread outside the room during the treatment. And also the wall also have a lead inside the door. And it is the shielding door. You can see there are 2 doors, double door, at the high energy linear treatment room. And also there are some signage should be hosted to alert all the people. For the radiation safety issue, it is a very important principle we need to know. We call it ALARA principle. As low as reasonably achievable, it should be applicable to the staff and patients. It aims to reduce the exposure to the radiation. Radiologists, image technologists, researchers, physicians, and other healthcare personnel all have a responsibility to minimize the radiation dose to patients, staff, society, and the environment as a whole, while maintaining the quality of imaging or treatment for which it used. The first one is the time. For people who are exposed to the radiation, in addition to the electro environment, electro background radiation, the limiting or minimizing the exposure time can usually reduce the dose from the radiation sources. The second one is the distance, such as the heat from the fire reduce as you move further away. It is same as if the dose of radiation decrease dramatically as you increase your distance from the radiation source. And the third one is the shielding. The barrier of lead, concrete, or even water can provide protection from penetration. In actual clinical environment, like the brachytherapy, the internal radiation, generally, we need to have a clear explanation of the radiotherapy to patients about the procedure, including the acute and chronic side effects they will suffer, like the risk of vaginal stenosis, bleeding, sexual problem due to the vaginal dryness, reassurance that they will not carry any radiation after each treatment or discharge. Patients will stay alone in the operation theater for the intracavity cervical brachytherapy. Let's see more detail and safety concern for brachytherapy. It is the ICB we call intracavity radiotherapy. It is an intracavity application. The radiation safety concern and protection, we should inform all the patient and family of the radiation hazard. We always ensure the principle by our principle, and the patient will stay in a shielded room, warning sign, discourage the visitor. And also that we have some care before and during the treatment. We should educate the patient about the procedure that they will need to do before the procedure, such as the vaginal douching, the bowel preparation, etc. And also, the patient need to strict bed rest in the afterloading machine area, and also limiting our nursing time as possible. We protect the nursing. And also, we need to group the nursing care together and provide the patient necessary item, provide adequate means of communication, because the patient will stay alone in the treatment room. So you can communicate with him or her by using an intercom or a calling machine. And also we need to monitor and document the position of radioactive sources, if any. And what's the care after the treatment? We need to keep the dressing in basin to be checked by the radiation safety officer for any dislodged sources. And also we need to notify them for any emergency issue, such as if in case the patient is cardiac arrest, we still need to perform the CPR as usual, but there are some mechanism or safety concern need to inform our safety officer. And also we need to advise the patient to keep good vaginal hygiene by douching, advise the patient before discharge, such as demonstrate and return demonstrate the procedure, advise them to educate them to use the vaginal dilatator, use of the pin jelly, etc. This one is the interstitial application. You can see that, but it's very used nowadays. The radiation safety concern is morally same as the previous one. We need to ensure the safety, but one thing is that is very important is that we check the number of the tube. And also the care during after treatment. We need to inform the patient, the nurse will organize the nursing activity and encourage the patient to perform as many self-activity as possible, and check the linen, bedpans, or other signs of dislodged implant, and inform our officer as well. For the oral administration, remember all the stuff inside the isolation room will have radiation until treated by physics, and confirm it is dropped down to the safety level. Then it can be taken out or disposed. So some disposable utensil or disposable glove will be used. So remember, use the glove for handling the patient's body secretion, because the body secretion will consist of radiation. Depends on the radiation level. And ensure all hospital staff and visitors are aware of radiation safety precaution or signage. This one is the iodine 131 for the treatment of the thyroid cancer of the patient. So after administration, we should address some nursing care, such as the radiation causing sign should be put outside of the door of the single room. Patients stay in a single room, and disposable items such as eating utensil or cup will be used. The non-disposable items such as the blood pressure monitor, all the things or linens should not be removed from patient room until treated for the radioactivity. The soiled item should be placed in a plastic bag, shielded and left in the patient room until treated. We also need to encourage the patient to have more fluid intake. Their stool or urine and emesis are usually discarded in the toilet in patient's room. Instruct the patient to flush the toilet 2 to 3 times after use. To deal safely and efficiently with the radioactive spillage, our nursing staff or all the healthcare professionals should wear gloves when handling the urinal, bedpan, and emesis, and wash the hands thoroughly with soap and water after removing the gloves. And any advice on the discharge for oral administration, we need to ensure the patient, the radioactive level is safe. There are some issues need to be advised, such as the possible side effect, avoid the intimate contact, especially keeping distance from the infants or pregnant women. Educate patient or family that patient's body fluid are temporarily radioactive. Handling body fluids by others should be avoided. To utilize the universal precaution and good hand washing when handling is necessary. Avoid breastfeeding, good hand washing, and double flush the toilet. This is another unshielded source we call the EGM-90. It is a beta particles. It usually in the treatment of liver cancer through the hepatic angiogram. The half-life is about 64 hours. So the patient need to stay in an isolation room about 2 to 3 days. Education is more or less same as before, such as the flush the toilet, wash the hand. If any injury occurs and blood is spilled, wash away any and spill with blood and water and a paper tissue and flush the paper tissue in the toilet. Patients should also be advised that epigastric pain may be occurred during the procedure. And also, we will usually administer the antacid as prescribed. The care after administration instructs the patient to double flush the toilet, as saying, advise on the discharge. Usually use the universal precaution and good hand washing. Double flush the toilet, clean clothes and linens. And for the patient admitted to ward for RD131, the mobile LED night shielding will be used for protective staff. Theoretically and clinically, one patient should stay in a single isolation room. But in actual case, because some hospitals are very busy, they may have 2 people in a single room. But if I've seen 2 people receiving same treatment in a single room, that the mobile LED can be used to separate them. And this is the signage posted outside the room, because the radiation will affect some electrical machines such as our pacemaker, our cardiovascular defibrillator, and also remind the pregnant women cannot enter the room, and also children are also refused to enter the room. So we always need to adhere to the rules. Remember the ELARA principle. This is an uncontrolled area, low unauthorized entry. What is the radiation limits for the public or healthcare professional? For the international standard in 1990, recommendation of the International Commission on Radiological Protection, the recommend dose limit for exposure associated with the practice for the public, for the whole body, is 1 MSV per year. For the healthcare provider, it is maybe more, it's 20 MSV per year. So that means the maximum permissible dose for radiation worker is 20 MSV per year. For the intellectual environment or electro background radiation, the level is ranged from about 1.5 to 3.5 MSV per year, but maybe it can be more than 50 MSV per year. For the pregnant worker, it is same as the public. It's more and it's less. It's 1 MSV per year. So the pregnant women should also notify her supervisor that she is pregnant, and also special arrangements should be made to adjust their working condition in respect of occupational exposure, so as to ensure that the dose limit to the fetus is not exceeded. How to measure the radiation for the healthcare providers? Usually we use the TLD, thermoluminescent material package, one radiation monitor package. The radiation will absorb by the TLD, then release energy during heat up. The amount of energy released is proportional to the radiation we receive. Hence, the radiation dose to the staff can be measured. Report will be generated for us to monitor. So remember, allow our principle all the time, reduce the time, plan the work, and lay out the working place well. Reduce the distance Never hold a source directly by hand. Maybe you can use a forceps, etc. Shielding is also important. The concrete raw, the lead shielding, and also some first best. We should promote radiation safety in our practice. So the radiation safety officer must be available in a working place. And usually it's a physics. They are responsible for implementation and monitoring for institution radiation safety program, including the training of personnel and monitoring of the exposure. And also some important science should be always held, strict custody of the RS, preventive maintenance, the QA program, and also the visits should have a contingency plan if there's a radiation hazard. Never forget the security issue. So you can see there's a strong string to lock the afterloading machine. But why we need to lock the machine? Because in some other country or some place, they can be used as a nuclear weapon. So this is my presentation. Thank you so much. Terima kasih.
Terima kasih. Thank you very much, Mr. Gavin, for your wonderful presentation and thorough one. Now we will open the question and answer session. So I would like to invite Ms. Suzanne again. So we have got lots of questions from the participants here that I would like to read. And most of the questions so far are for Ms. Suzanne. So Ms. Suzanne?
Hi.
Right. Thank you very much. Yes, so there are plenty of questions here. We've got 15 questions from the participants. So for the first question is, when the patient is having the chemotherapy, they can be accompanied by the family?
When the patients, you mean?
During the patient chemotherapy, can the patients be accompanied with the family?
Oh, I think is from the healthcare perspective, for the patient's view, is a good thing if the patient's family can accompany with the patients during the chemotherapy administration, and even as a healthcare worker, we can engage. We can take this opportunity to engage the patient's relatives to care, to learn how to care the patients, the probable side effects after the treatment, and to help them being more confident to handle. But I think COVID-19, as the COVID-19 happens in all countries in the world, so most of the healthcare institutions should have set the guides, the rules, and to restrict the visitors to come to the healthcare setting, or ask the patient's family to wait outside during the patient treatment. So I think it's the same situation in Indonesia, is it?
Yeah, we also have that kind of.
Yeah. So I think we hope the COVID-19 can disappear very soon. Then our visitor, the patient's family, can come with the patients very soon. We hope to resume this practice. Yes.
All right. Thank you. So for the next question is, we have a question from Pak Rudi, please. So there is a case of the patient post-chemotherapy. 3 days later, there is a complaint like burn. So I think it's extravasation, isn't it? So patient chemotherapy 3 days after they have like a burn in the area of infusion site. So is it also called chemotherapy? Is it also called extravasation?
Halo, Mas Christian.
We cannot just simply tell that this is extravasation, because extravasation is mostly related to the infiltration of the drugs that can cause long-term tissue necrosis. Then we label this situation as extravasation.
Muter-muter jaringan.
Mohon maaf, peserta bisa di-mute. Sorry.
If the infiltrated drugs is like the drugs, for example, 5-FU, I just call some example, 5-FU or the say carboplatin, then some nurses may experience the patient's reaction is not so severe. It's just very light. The patients may just complain mild redness and discomfortable after the drugs go out from the blood vessel afterwards. Then the reaction is not severe and long-term. Then for this situation, it is just infiltration. We call this infiltration. Then so how do you recognize what the patient's reaction is extravasation or not? You need to identify what the cytotoxic drugs the patients have infiltrated. If the drugs is related to the say doxorubicin, then you can estimate the reaction is very severe and long term. So you should take the close reaction as the patients come back for your monitoring next day. If the patient is inpatient, then you need to monitor the patient very regularly and closely. I think some reaction may happen a few days or a few weeks. So you should monitor the patient closely.
Alright, thank you. Jadi untuk tadi pertanyaan pertama yang tentang apakah pemberian kemoterapi pasien bisa didampingi keluarga, itu sebenarnya berkaitan dengan kebijakan di rumah sakit ya. Tapi sebenarnya dapat didampingi oleh keluarga. Hanya karena sekarang ini ada COVID, jadi peraturannya itu tidak boleh didampingi keluarga kalau di Hong Kong seperti itu. Kemudian tadi untuk pertanyaan yang kedua, apakah ini disebut ekstravasasi juga? Kalau dari Miss Susan, jadi ini harus dikaji dulu, terutama dari obatnya, apa yang sudah didapat dari obatnya ini dari pasien. Nah, kemudian next question, please. So there is another question for the patient, pre-chemotherapy patients. Do they have to undergo laboratory screening? And if yes, what do we have to do for that screening? Thank you. Pre-chemotherapy.
Yes. As a nurse, I think in the setting, we may have several time points. We need to do the chemotherapy screening. Say, before the patients come to see doctor, before the doctor consultation, I think in most clinic, the nurses will assist the doctor to screen the laboratory results, whether they is okay or not, whether the patient need to repeat the blood counts if the blood count is not okay yet. This is the first time point screening. The second time point is the patients when the doctor prescribed the chemotherapy, the patient need to have the administration. Before administration, the second time point is the assessment. The nurse need to assess whether the patient is truly fit for chemotherapy. This is the second time point. And when the nurse give the drugs right ahead before give the drugs to the patients, then the nurses should check the patient's information, the medical record, against with another nurses, whether the patient really fit for the chemotherapy drugs and whether the particulars is right. So here should be roughly 3 time points of an assessment.
Baik, jadi tadi itu ada 3 waktu yang kita perlu melakukan screening lab. Yang pertama itu yang pertama tadi apa ya? Jadi setelah dokternya itu memberikan memberikan prescribe untuk kemoterapi, kemudian sebelum itu juga kita perlu ketika dokternya melakukan pemeriksaan, kita kan akan mendampingi dokter gitu. Jadi itu juga perlu dilakukan pemeriksaan lab. Kemudian setelahnya itu setelah diberikan kemoterapinya. Next question please, Pak Rudi.
Iriska. Yes. You may explain to the colleagues that the screening and assessment is a big topic. You may need to address in another seminar or section.
Alright. Iya, jadi Miss Susan tadi menambahkan bahwa screening itu sebenarnya adalah topik yang besar gitu. Jadi perlu ada seminar sendiri untuk membahas topik ini gitu ya. Next question please, Pak Rudi. Oh ya, sudah ya. What do we have to do? So this is the next question. What do we have to do first time after we found out the patient is having extravasation?
As I just mentioned, if you doubt, you suspect the patient, the drug is go out from the blood vessel, then you notice some signs and symptoms, redness. And the patient may even complain pain over the drip site. Then you then check whether there is any blood return. If the infusion you find the infusion go not smoothly and there is no good blood return, then you need to suspect this is the case of extravasation. You need to stop the IV infusion of the chemotherapy drugs, stop it, and then change the IV tubing. Use a newly plied IV tubing, plied with the normal saline. We connect another new tubing to the IV tube site. Or if you find the blood return is not good, then you need to you may need to
Tolong di mute, Mbak Devi. Mbak Devi, tolong di mute. Ya sudah. Please carry on, Miss Susan. Hello, Miss Susan. Miss Susan?
Mbak Tita, Mbak Susan masih di mute, kasih tahu.
Oh, Miss Susan, would you please unmute yourself? Hello, Miss Susan. Miss Susan, can you hear me? Ya, jadi tadi yang sudah dijelaskan oleh Miss Susan adalah langkah pertama yang harus.
Can you hear me?
Oh yeah, now I can hear you.
Sorry.
Please carry on.
I repeat. If extravasation, if you find the patient's drug when the patient complain mild pain or redness, then you doubt whether the drug is going out from the vein, then you can check whether the blood return is okay or not. If there is no blood return, then you can suspect this is the case of extravasation. You can remove disconnect the IV tubing and even remove the drip site, remove the drip out. If it's most probably extravasation. When it happens, you need to stop the IV chemo first and then remove the drip if there is no antidote. But if there, for the drug, in case there is antidote, you can discuss with your doctor whether he or she want to use the antidote. You can leave the site here to wait whether the doctor want to give the antidote through the angio cap. If they don't want to give antidote, then the angio cap can be removed out. Okay?
Oke, jadi kalau tadi ada pasien terjadi ekstravasasi, yang pertama kan dilihat dulu pengkajiannya ya. Kalau misalnya pasien yang mengeluhkan ada nyeri atau dilihat ada kemerahan, kemudian dicek venanya itu apakah, maksudnya saluran infusnya itu apakah ada blood return atau tidak. Kalau misalnya tidak ada blood return, dicurigai ada ekstravasasi. Dan yang pertama harus dilakukan adalah harus di stop kemoterapinya, kemudian ditanyakan kepada dokter apakah akan diberikan antidot atau tidak. Kemudian juga bisa di-flush dengan tadi di-flush dengan NaCl ya, Susan mengatakan gitu. Jadi itu tadi. Kemudian pertanyaan berikutnya, next question. So this is another question. How is the PPE usage in Hong Kong for the procedure of the chemo closed system?
Oh, I heard from some company, some medical device company. They the sales come to show us there is the chemo. There is some called closed system. But in Hong Kong, we don't yet use the chemo closed system. The syringe can be connected to the closed system device, and they claim this can prevent the chemo coming out. In Hong Kong, we have the pharmacist, the cytotoxic pharmacist. They will prepare the chemo inside their bicarbonate. In Hong Kong, in the old days, the nurses, we prepare the chemo ourselves. But nowadays, they have changed. The practice is now performed by the pharmacist. They reconstitute the chemo drugs inside the bicarbonate, which is safe. Is a closed cabinet to do the practice. And as I know, the pharmacist need to down up and wear the thick gloves and the respirator during their preparation of the chemo drugs.
Ya, baik. Jadi tadi Susan sampaikan kalau zaman dulu itu memang masih perawat yang melakukan persiapan kemoterapi. Nah, tapi sekarang ini itu sudah dilakukan oleh farmasis dan mereka memang menggunakan APD yang APD khusus ya. Jadi gown up itu, kemudian itu tadi penggunaan APD-nya. Terus Susan tadi juga menambahkan bahwa memang ada dari perusahaan farmasi yang menawarkan bahwa ada satu PPE yang bisa bisa langsung terhubung dengan kemonya itu ya, tapi tadi itu ya begitu. Selanjutnya, pertanyaan berikutnya. Ya, ini we have a question from Ibu Kemalarita. So how about the chemotherapy if PPE? Oh, ini mirip pertanyaan yang tadi ya. How about the chemotherapy PPE if we use a closed system cannula chemotherapy administration? Hello, Miss Susan.
For these questions, I interpret is asking how do they need to use the chemotherapy PPE if they use a closed system? Is it?
Yes.
Closed system what? Closed system what? This is chemo administration.
Ibu Rita, maybe you can unmute yourself and explain it.
From some of the company product the closed system cannot for the safety for the provider. Yeah, we need or not use the PPE again, like gown, mask, and glasses, protect for our eyes, something like that. If you use the closed system cannot. I mean that, Susan.
No, I just, as I know, there is some company, they sell the chemo, the closed system. This is type of syringe. The device can be connected to the syringe to make the chemo can be reconstituted through the closed system. So that you do not need to aspirate the chemo to your syringe in the room air. It is dangerous. But in Hong Kong, we don't. We seldom to use the so-called closed system in the clinical. As I just said, all the chemo reconstitution, we have our standard practice. We need to perform it in the pharmacist inside the safety bowel cabinet. It's a closed cabinet with the ventilation, high ventilation. Is inside a closed room. Other people cannot get access to the room. So all the chemotherapy drugs are basically prepared inside the pharmacist, the safety bowel cabinet. So in Hong Kong, our nurses seldom to prepare the chemo ourselves. So it's not, is it the practice still in Indonesia performed by the nurse here?
Rita, yeah, Ms. San just asked if the nurses still perform the chemotherapy here in Indonesia.
I mean that not for the handling chemotherapy, Susan. If the chemo given by nurses, yeah, usually the nurses use the PPA, yeah, complete PPA from the head, gown, mask, and glasses.
Oh, okay.
And we have two kind of model to give the cannula, to give the cannula so the chemotherapy to the patient. With the first model is usual cannula, and the other model is the closed system cannula. How about if we use the closed system cannula, we have to use the completely PPA or not?
Oh, yes.
Just my question.
Okay. Regarding other setting, nowadays they are talking about the IV treatment. They promote the closed system concept. So in our setting, also highly promote the closed system concept. IV treatment. But even though we use the closed system inside our clinical setting, our nurses have to still gown up, wear the PPE. But the level of the PPE, how stringent it mostly depends on how safe the closed system used in your clinical setting. But basically, the nurse need to wear the surgical mask, wear the gloves, the chemo. Yes, yes.
Yes.
This is okay, but maybe for the eyes.
Yeah.
For the eyes, because when she hand up the chemo here, if the tubing is disconnected, then the chemo may have chance to spill out. So the nurse, I recommend the nurse should handle the chemo below eye level. Below eye level, then secure when they secure the tubing. The tubing is connected to the bottle. Then they hand up. When they hand up, they should be careful. Otherwise, the chemo may happen to spillage and spill to the eyes. And the PPE should have also have the gown. Some countries, Western countries, in USA, they recommend to wear the long sleeve PPE. But in United States, in UK, I observed some nurses, they use the apron. They gown up with the apron, which is more convenient and more permeable. They feel can be wet and not so hot, because the full gown is very hot. So some area they may adopt the apron, but in most Western countries they recommend the gown with the long sleeve and tie up at the back. Okay.
Okay.
For the head is not necessary.
Yeah, thank you. Maybe Mbak Tita tinggal disambung untuk yang lain.
Iya, jadi tadi pertanyaannya tentang PPI itu seperti yang tadi sudah ada di gambar, PPI kalau misalnya memberikan kemoterapi closed system itu bisa seperti yang tadi menggunakan surgical mask, menggunakan masker bedah, kemudian menggunakan sarung tangan, dan menggunakan kacamata tadi yang belum ada ya di gambar itu ya. Tidak perlu pakai penutup kepala, kemudian untuk apronnya itu kalau di negara barat itu mereka ada yang pakai apron saja gitu, jadi supaya lebih nyaman juga itu, dan itu sudah cukup gitu. Kemudian next question please. What do we have to do to prevent extravasation? Is there any salve? Is there any ointment that we can give to prevent extravasation for the chemotherapy patients? This is the question from Mrs. Ann as well.
Yes, as I just mentioned, for any drug going out from the blood vessel to the tissues, when it happens, we need to firstly identify what is the drug. If the drug is which can cause significant long-term necrosis reaction, then this is the extravasation drugs. Say the doxorubicin I just mentioned, for the which is used to treat the breast cancer. Doxorubicin, the red one, which is red in color, it is going out to the tissues. Then there is some drugs called DMSO. You can apply locally, apply the DMSO on the patient's the drip site 3 to 4 times a day. Apply it and just leave it open on the skin for 7 days. It is called can help to relieve the reaction.
How about to prevent it? Is there anything that we can do for like ointment that we can use for prevention?
For prevention, there is no ointment to prevent any extravasation. The prevention is only you need to choose a good way to prevent the drugs, to prevent the cannula, the angel cap coming out from the blood vessel to the tissues.
All right.
So the chemo nurse should have a good technique to do the cannula insertion. Is very important. Or some countries in overseas, Western countries, they perform the PICC line. They insert the PICC line or the Hickman line for giving the extravasation drugs. But it's so expensive and not convenient for so many patients. They don't like use the PICC line or central line.
Ya, baik. Jadi tadi pertanyaannya kalau untuk salep yang bisa digunakan untuk mencegah ekstravasasi itu tidak ada ya. Yang ada adalah untuk merelief untuk kalau ekstravasasinya sudah terjadi, misalnya pasiennya itu diberikan doxorubicin, kemudian dan terjadi ekstravasasi itu bisa diberikan DMSO 3-4 kali per hari. Tapi kalau untuk pencegahan tidak ada salepnya. Yang bisa dilakukan adalah dengan memberikan pasien kanul yang tepat, kanul vena yang tepat, kemudian juga teknik insersi venanya itu juga harus tepat, dan juga kalau di luar negeri itu mereka ada yang pakai PICC line untuk mencegah ekstravasasi. Jadi bisa diberikan PICC line juga, walaupun itu lebih mahal, jauh lebih mahal, dan pasien juga kurang nyaman juga gitu ya. Itu mungkin. Next question, please.
Rista.
Oh yes.
Or you can ask the nurses can produce some leaflets, make some information pamphlets to educate the patients to monitor their drip sites. And ask the patients who receive the doxorubicin or other vesican drugs, they don't move their hands. Don't move. Keep the drip. Keep the arm with the drip stable, not moving. Then it will prevent the drugs, the cannula coming out from the blood vessel.
Ya, jadi tambahan dari Ibu Susan itu tadi bisa diberikan leaflet untuk pasien. Jadi terutama untuk pasien yang mendapatkan obat yang rentan mengalami ekstravasasi, misalnya doxorubicin, itu tadi bisa diberikan leaflet yang intinya pasien itu supaya bisa memantau memantau area penusukan venanya itu, supaya kalau misalnya ada tanda terjadi ekstravasasi itu bisa segera ketahuan, dan pasiennya itu juga diminta untuk supaya tangannya tidak bergerak-gerak gitu ya, untuk tangannya tetap ada di tempatnya, jadi nggak bergerak-gerak untuk mencegah ekstravasasi juga. Jadi perlu diberikan edukasi itu juga ke pasien. Oke, thank you. Next question, please.
Mbak Tita, bisa Ibu tambahkan sedikit?
Oh iya.
Ya, yang tadi pencegahan ekstravasasi sebetulnya bisa dilakukan dengan flushing. Flushing itu harus sampai selesai. Sering sekali pasien-pasien datang ke rumah sakit, dia obat kemonya sudah selesai, dia buru-buru pingin pulang. Jadi artinya sebetulnya masih ada di dalam pembuluh darah itu tertinggal, itu yang berisiko membuat ekstravasasi. Jadi flushing harus diselesaikan sesuai dengan programnya. Karena pasien obat kemonya udah habis, udah ya suster ya, udah ya, gitu. Nah, itu salah satu risiko. Jadi edukasi pasien bahwa flushing harus diselesaikan selama 30 menit, ya 30 menit, gitu. Walaupun kemonya udah selesai. Terus tadi barangkali ada pertanyaan dari peserta tadi yang menanyakan, kalau ada luka seperti luka bakar habis kemo, itu adalah ekstravasasi. Itu jelas ekstravasasi, jadi kita perawat harus lebih hati-hati lagi. Tadi Susan sudah bilang untuk menghentikan dan segera lapor kepada dokter untuk selanjutnya apa strateginya. Dan betul sekali tadi untuk kalau sudah kena mau diapain, itu satu-satunya adalah peningkatan kenyamanan pasien, karena itu sangat perih sekali dan rasanya seperti terbakar. Jadi kenyamanan bisa dikompres dingin, dan itu selanjutnya adalah ke bagian perawatan luka. Kami di klinik untuk di rumah sakit kanker, ya bagaimana jaringannya cepat kembali dan tidak tambah meluas. Barangkali itu saja Mbak Tita. Jadi agar teman-teman lebih cepat deteksinya, kalau ada ekstravasasi jangan tunggu sampai ada luka bakar, Makanya perlu diobservasi, perlu diedukasi pasien sebelum pulang, selalu melihat mulai ada tanda nyeri, merah, itu mulai segera lapor. Ya, seperti itu. Barangkali itu saja.
Ya, terima kasih Bu Rita penjelasannya. Next question, please.
The last question.
So this is for Mr. Gavin. My family member with lipoma cancer and undergoing radiotherapy every day for 35 times. How is the effect of radiotherapy to other organ and treatment after radiotherapy? Thank you.
Yes, and for the side effects, it usually depends on the radiation dosage and also the radiation area, because I don't know where is the area of the lipoma. But usually, if the radiation, the common side effect is also we call the radiation skin reaction or called radio dermatitis. If she or he receive 35 dose of radiation, the radiation skin reaction is also the common happen. And maybe I can share some photo that you can have a look. Do you mind?
Yes, sure. Thank you.
Okay. Yeah. Okay. This one is the head and neck cancer patient, and for the lipoma, I think it's almost the same. This is the radiation skin reaction is initially maybe at the 20 doses. There's some erythema, we call maybe grade 1 radiation dermatitis, and if more severe, maybe grade 3, grade 2, or grade 3. This is usually commonly happen. Usually it's red in color, and the skin is dry, and the patient will feel itchy. This is commonly happens. So the most important thing is that we advise the patient don't scratch the skin, and maybe during the after the bathing, use the soft cloth to make it dry. Don't pull the skin. Don't scratch the skin. And also we don't advise the people to use some cream, because the people do not know the content of the cream. Maybe very oily. It can induce more severe reaction. So we do not recommend any cream for the people. The most best method or best practice is cleansing. Maybe everyday cleansing is good enough.
Everyday cleansing?
Everyday cleansing, yeah.
Alright, thank you. Jadi tadi ini Mr. Wong sudah memberikan contoh gambar reaksi radiasi di kulit yang bisa menjadi efek samping dari radiasi. Jadi kalau misalnya memang terjadi seperti ini, tidak disarankan diberikan krim apapun gitu ya. Yang bisa diberikan adalah dibersihkan aja setiap hari gitu. Ada lagi pertanyaan berikutnya atau tadi yang terakhir ya pertanyaannya Pak Rudi ya? Yang bisa
ada lagi Bu, satu lagi Bu.
Ya,
untuk
baik,
Mr.
satu
Wong.
lagi.
Ya, untuk Mr. Wong.
Okay, another question for Mr. Wong.
Yeah.
So this is the question, do you have any suggestion for xerostomia-related radiotherapy for nursing practice?
Because the xerostomia is usually is for head and neck cancer patient, I think. Because the head and neck cancer patient will receive a very high dose radiation to our head and neck region. It affects our salivary gland. There are three salivary glands over our region. But after the radiation, the salivary gland, the secretion will be decreased or evenly lost for a while, maybe a month or 2 months. The xerostomia will usually better after 2 months or 3 months later on. But during the treatment, the patient will still feel dryness of the mouth and also pain of the mouth. So we can advise him or her to drink enough water, this much thing, and maybe take some soft and moist food to prevent the discomfort. But it cannot be totally prevent. And after the radiation, maybe 2 to 3 months, the xerostomia will be more improved later.
Yeah, Baik, jadi untuk kasus serostemia itu tadi memang tidak ada yang untuk bisa pencegahan, tapi kalau misalnya terjadi serostemia, itu pasiennya bisa dianjurkan untuk banyak minum, kemudian makan makanan yang lembut dan lunak, dan itu akan hilang dalam sekitar waktu sekitar 3 bulan tadi ya. Itu jadi biasanya memang terjadi kalau misalnya pasiennya ini head and neck cancer itu biasanya umum terjadi karena radiasinya itu mempengaruhi kelenjar ludah gitu. Jadi makanya sering terjadi serostomia. Itu tadi.
Rizka,
Yes.
can I supplement something?
Sure.
For the audience asking any research updated in the serostomia, as I know, 10 years ago, some doctor, they do the research in a new drugs called amifostine. Probably some of the nurses may come across these drugs many years ago. They test whether they can use the amifostine to relieve the dry mouth, the salivary, due to increase salivary gland secretion. But after the clinical trial, they found no significant effects in the amifostine, because when the amifostine is pay some protective for the salivary gland against the radiation therapy. But in another aspect, they will probably make some risk. There may be the cancer cells, protect the cancer cells from the salivary gland. So nowadays the FDA do not recommend to use the amifostine to prevent the serostomia for the head and neck radiation. So for the prevention, nowadays in the RT, they have some new technique called the IMRT, the integrated modulated radiation therapy. IMRT.
Intensity modulator.
Yeah. This is not new. This technique is already not new. It's already 10 years. Most countries, the doctors, they adopt the IMRT for the head and neck radiation therapy. So the patient's serostomia, the level has been decreased since the use of the new technique. And any new drugs for this aspect, we don't yet hear too much. But some guidelines from our nursing, what can we do? We can help the patients to rinse the mouth. Use the tube one. The tube method is to use the baking soda. To use the baking soda, mix up with the water for the rinsing. It can help to remove the crust. The mouth rinsing is a good one to help the patient. And we think serostomia can be resolved after a long period of time after the radiation treatment.
Yeah, thank you very much. Jadi tadi ada tambahan.
And can ask the colleagues to try to educate the patient to use the chewing gum.
Chewing gum. Yeah,
to chew. It will help to increase the secretion of the saliva.
Or saliva product. Yeah.
Thank you. Jadi tadi tambahan dari Ibu Susan, memang dulu itu sekitar 10 tahun yang lalu ada penelitian yang menyarankan ada satu jenis obat, apa tadi namanya Bu ya? Iya itu, tapi kemudian obatnya itu ditemukan bahwa ternyata tidak terlalu berpengaruh signifikan gitu, jadi tidak disarankan intinya obat itu. Nah untuk sementara ini belum ada penelitian yang menganjurkan tentang obat-obatan yang bisa mencegah serostomia lagi, tapi yang bisa kita lakukan sebagai perawat adalah tadi dengan meningkatkan kenyamanan pasien gitu ya. Contohnya dengan pasien itu bisa berkumur dengan baking soda dan air, Jadi pasiennya kumur-kumur, kemudian yang berikutnya lagi untuk meningkatkan produksi salivanya itu dengan makan chewing gum, dengan makan permen karet gitu. Walaupun sekarang ini kalau untuk mencegah serostomia itu ada tekniknya yang tersendiri gitu, yang intensity modulator radioterapi gitu. Jadi itu sudah membantu mengurangi kejadian serostomia gitu ya. Okay, so yeah.
May I give a question to Mr. Wong?
Sure.
One question. Mr. Wong, how about the dermatitis radiation? Can I use the burnazing salve? Usually in Indonesia, we use that burnazing for the dermatitis radiation. Dermatitis.
For what radiation? Sorry, I can't hear. Sorry.
Yeah, for the dermatitis radiation. The wound, the irritation by the radiation.
So I can't catch your meaning. Can't catch your question.
No, look, lecet Pak. Irritation. Irritation caused by radiation. Make our skin irritation and
skin irritation.
We call that usually a dermatitis radiation. And in Indonesia, usually we use the burnazing salve, burnazing ointment.
Oh, ointment.
How do you think about that?
Yeah, but previously I think because some international study have because different country or different the place we have different practice. But usually we do not recommend any oily ointment to apply on the skin. If you think the cream or the ointment can have some soothing effect, such as usually because aloe vera we do not recommend, but some people still think it's very itchy, it's very discomfort. So we will advise them the aloe vera cannot prevent the irritation or the skin reaction. But if you think it can cause you a comfort or more comfortable, then you can apply a little bit after everyday radiation. But it can only have some soothing effect only.
Okay.
This is my question. Yeah.
Thank you.
Yeah.
Jadi tadi pertanyaan Bu Rita adalah untuk kasus dermatitis radiasi, apakah bisa diberikan burnazin salep gitu ya? Kalau dari jawabannya Mr. Wong adalah sebenarnya tidak disarankan untuk memberikan salep yang sifatnya minyak gitu atau salep untuk dermatitis. Walaupun memang kenyataannya praktek di negara-negara itu bisa beda-beda gitu ya. Nah, sebenarnya mungkin pasien itu mungkin merasa gatal sekali atau merasa tidak nyaman sekali, mungkin bisa diberikan, misalnya ada yang memberikan aloe vera, itu bisa saja diberikan setelah radiasi setiap hari, tapi itu efeknya hanya untuk supaya nyaman aja sebenarnya, tapi tidak menyembuhkan. Gitu ya, Bu ya?
Rita, I would like to supplement something. Because we are not so familiar with what ointment commonly used in your country, in Indonesia, but we would like to ask you to check whether the cream or the ointment contains steroid. If it contains steroid, then we should bear in mind to pay attention in this, because most patients, the skin will feel some hot, redness, and some itchiness. So they may, when the doctor gives them the steroid cream, then the patient may feel very comfortable in the first few days when they apply to the irritated skin. But for the long term or more than 4 or 5 days, then the skin will become a little bit thin after they use a long term of steroid on their skin, which is not favor the wound, because if the wound happen in your skin, that means the dermis is exposed. That when the patient finds some serum coming out, that means the wound is coming out. Then any cream with steroid need to be stopped at once. When you find there is wound formed on the skin, then the steroid cannot be used anymore. Okay, so some doctors are not aware of this. They always need to remind the patient not to use the steroid again when the wound is coming out. So as for some patients, they continue to use, their wound will become bigger when they come back up the next visit. So bear in mind to instruct the patient not to use the steroid when there is open wound.
Okay, thank you.
And also I can have some supplement, because I've heard that there's a cream called a Strata. I've seen some study in Australia and New Zealand. It's called a Strata XRT cream. But this is on the research base now, so we can have more information later on that we can choose this cream maybe later, will it work or not. This is called Strata. Maybe you can find some search in the internet.
Yeah.
Okay, thank you, Mr. Wong.
Ya, jadi tadi tambahannya dari Miss Susan adalah yang perlu diperhatikan apakah obat, kalau misalnya diberikan obat untuk dermatitis itu tadi, apakah obatnya mengandung steroid atau tidak. Jadi kalau misalnya terjadi luka, itu harus dihentikan obat steroidnya itu, karena bisa menghambat untuk penyembuhan lukanya. Kemudian tadi tambahan dari Mr. Wong adalah ada yang obat yang terbaru dikeluarkan, itu namanya Strata, jadi mungkin bisa dicari tahu juga tentang itu. Gitu ya. Itu ya Bu ya?
Okay.
Okay, so this is the end of our question and answer session. Thank you very much for Ms. Susan and also Mr. Gavin for all your answers in this wonderful session. Okay, so now I would like to present the certificates for the speakers. So please, Pak Rudi, to preview the certificates for the speakers. Pak Rudi. Sekarang kita akan sesi pemberian sertifikat untuk speaker. So this is, thank you very much for Ms. Susan Mak on behalf of the Indonesian Oncology Nurses Association. Thank you very much for becoming our speaker today. And the second certificate is for Mr. Gavin Wong, Kafai Wong. Thank you very much for becoming our speaker today. We really appreciate your sharing your expertise and your experiences. Thank you very much.
Thank you.
Thank you.
Terima kasih.
Terima kasih.
Thank you.
Terima kasih.
Bye.
Terima kasih.
Terima kasih.
Salam sehat selalu, Mr. Wong.
Terima kasih.
Thank you.
Thank you.
Thank you,
Mr. Wong, Miss Susanna.
Thank you, Mr. Wong.
Yeah, thank you. Terima kasih.
Thank you.
God bless you.
Thank you.
Okay.
Apakah absen lagi?
Okay, Alhamdulillah. We have finished the first session well and smoothly. For all the participants, I ask all of you to stay in this room. Thank you for Ms. Ariesta, who has guided the first session well, and I will say thank you to Ms. Susan and Mr. Wong, who has shared the awesome material to us. Sobat Nurse Himponi, kami harap semua masih tetap fokus untuk mengikuti webinar ini, karena masih ada satu sesi yang akan kita ikuti. In second session, we will discuss about promoting patient safety in pediatric oncology that will be delivered by Mrs. Dr. Aleni Dekania, Sarjana Keperawatan MASI, and about closed system infusion therapy in oncology that will be delivered by Mr. M. Nafis G., Sarjana Farmasi Apoteker. In this session, we'll be guided by our expert moderator, namely Nurse Nani Sutarni, Sarjana Keperawatan, Spesialis Keperawatan Onkologi, Magister Keperawatan. Before she guides this session, allow me to introduce her. Full name of her is Nurse Nani Sutarni, Sarjana Keperawatan, Spesialis Keperawatan Onkologi, Magister Keperawatan. Beliau lahir pada tanggal 24 Februari, tinggal di daerah Tangerang. Beliau saat ini bekerja di Rumah Sakit Kanker Darmais sebagai Ketua Komite Keperawatan di Rumah Sakit Kanker Darmais. Beliau sudah mengikuti beberapa pelatihan dan juga kursus terkait kanker, mulai dari short course, baik di level nasional ataupun di Asia Pasifik. Beliau juga sebelum menjadi ketua komite pernah menjadi sebagai pengawas keperawatan dan juga sebagai penanggung jawab ruangan. Pernah juga beliau sebagai manajer unit keperawatan rawat inap. Namun saat ini selain sebagai ketua komite keperawatan di Rumah Sakit Kanker Darmais, beliau juga sebagai survivor CARS. Riwayat mengajar beliau selain di Akpernas juga terakhir di IPDC PPNI DKI Jakarta pada mata ajar onkologi nursing training untuk perawat Bangladesh. Dan juga untuk riwayat organisasi, selain bergabung di PPNI tentunya, beliau juga bergabung di HPMI, di Himponi, dan juga sebagai anggota di Kolegium Spesialis Onkologi. Baik, tanpa memanjang waktu, alright Sobat Nurse Himponi, let's follow the next session. Welcome to Nurse Nani Sutarni, Sarjana Keperawatan, Spesialis Keperawatan Onkologi, Magister Keperawatan.
Terima kasih Ibu Pera yang telah memperkenalkan saya. Jadi saya tidak perlu perkenalan lagi ya. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera buat kita semua. Saya punya salam lagi. Salam sehat, salam tangguh, sama salam caring untuk Sobat Nurse Himponi yang telah hadir dan stay saat ini. Di mana kalau kita lihat partisipannya masih tetap stay di sini ya, sekitar 440-an. I'm very happy to see you by Zoom and welcome all of you to be the second webinar today. Sangat luar biasa antusias Sobat Nurse Himponi dalam meningkatkan pengetahuan di bidang onkologi. Pada sesi pertama tadi cukup menarik banget ya, di mana banyak teman-teman antusias untuk mengetahui, memperdalam bagaimana safety di mana aja tadi, safety di dalam penata laksanaan kemoterapi, safety di dalam radioterapi, ternyata banyak hal yang harus kita pelajari dan banyak hal yang harus kita ketahui. Nah, pada sesi yang kedua ini tidak kalah penting lagi bahwa pada sesi ini akan bagaimana seorang perawat melakukan safety di dalam melakukan perawatan onkologi khususnya di anak. Dan tadi banyak pertanyaan terkait dengan closed system. Alhamdulillah pada webinar ini teman-teman yang tadi mengetahui apa itu closed system nanti akan dibahas oleh pada sesi yang kedua ini. Pada sesi 2 ini ada 2 pembicara yang sangat pakar di bidangnya. Yang pertama adalah Dr. Aleni Dekania. Ini Bu Aleni, saya senangnya manggilnya Bu Alen karena namanya agak sulit ya, sulit mengucapkannya. Bu Alen ya, Bu Aleni Dekania SKP MHSC dengan materi Promotion Patient Safety in Pediatric Oncology. Sedangkan yang kedua adalah Bapak M. Nafis Gozali ya, yang akan SPAM APT yang akan membawa materi tentang Closed System Infusion Therapy in Oncology. Sebelumnya kedua pembicara akan tampil memberikan paparan sesuai dengan materinya, mungkin saya akan membacakan CV dari yang pertama yaitu Dr. Aleni Dekania SKP MSc. Nah, di sini banyak sekali beliau memang dari awal sudah aktif di pendidikan di Fakultas Ilmu Keperawatan UI dan saat ini beliau adalah bekerja sebagai asisten profession Pediatric Nursing Department di FIK UI. Pengalaman beliau juga sangat banyak sekali di bidang beliau dari 1993 sampai sekarang sebagai dosen dan juga peneliti. Beliau ini memang concern sekali terhadap pediatrik, terutama pediatrik onkologi. Kemudian beliau juga sebagai pada tahun 2021 sampai 2023 sebagai Direktur Health Science Cluster University Indonesia dan juga beliau mempunyai pengalaman di dalam sebagai sekretaris eksekutif fakulti di FIK UI dari 2009 sampai 2012. Pengalaman organisasinya juga banyak, beliau aktif terlibat di PPNI, organisasi anak, kemudian juga di Center Education Nursing, kemudian juga sebagai asesor di dalam akreditasi pendidikan nursing. Tulisan beliau sangat banyak sekali ya yang dipublish, baik penelitian. Memang kalau kita lihat teman-teman bisa membaca concernnya adalah di pediatrik onkologi. Kemudian beliau juga membuat modul yang terkait dengan perawatan anak onkologi. Mungkin itu CV singkat yang bisa saya sampaikan mengenai Dr. Alenia Dekania. Mungkin untuk lebih kita mendengarkan materi yang akan disampaikan kepada Dr. Alenia Dekania untuk lebih bagaimana kita memahami safety di bidang onkologi. Now allow me to welcome the speaker, Dr. Aleni Dekania SKP MSc, to make the presentation promotion patient
Thank you, Bu Nani, for introducing me. I'm very happy to be here and good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. Can you hear me clearly, Ibu Nani?
Clear,
Clear. Okay. Yeah. Good morning, everyone. Good morning, Sobat Nurse Himponi. Thank you for Ibu Rita, the President of Indonesia Oncology Nursing Association, who invite me to join this webinar. Today I will share my presentation promoting patient safety in pediatric oncology. Please, Pak Rudi, can you help me to share my slide? I'm sorry because I cannot share the share screen because of my laptop, not because of the signal or something.
Okay.
I think something wrong with my laptop.
Yes. Sudah tampak.
Yeah, thank you. Thank you, Pak. Yeah, this is my title for presentation today. Next, please. Yeah. Could you help me to white screen? Yeah, thank you. Yeah, this is the outline. A little bit different with the previous presentation. I focus on pediatric cancer and for focusing the patient safety initiative in pediatric cancer. Next. Yeah. The number of cancer in children is increasing year by year, and we can see that almost 30% of patients with cancer will die, and the number of cancer disease different between children and adolescent. When children are under 14, we can see that acute lymphocytic leukemia is the most cases, the increasing cases in children. However, in adolescent, age 15 to 19, the Hodgkin lymphoma is the highest case. In Indonesia, for especially in Darmais Hospital, the national referral for cancer, we can see that the number of cases in childhood cancer is increasing year by year, and leukemia is still the highest cases in children. Next. So every child faces the journey for cancer patient journey since they experience symptoms and diagnosis, and then treatment choice and decision to running the therapy cycle until they survive or disease progression happen. As we can see in the bottom, that nurses role is everywhere in every stage of therapy, such as in diagnosis, in therapy treatment choices, and in therapy cycles during the active therapy. And then when the children come to end of life, we stay for the patients. Next. This is framework for making healthcare safer from American Health Research and Quality, that all patient threats to safety because of medication management issue, healthcare associated infection, nursing assess sensitive event, procedural events, and diagnosis errors. Even they stay in or exposed in preventive services, acute condition in ER, or a chronic condition during the therapy cycle, or come to end of life. So as nurses and healthcare provider, we have to make sure that our patient is wellness conditions. So we have to practice safety in all setting. Next. Institute of Medicine resurgence of quality improvement in healthcare. At least six principles that make sure our patient get safety practice, safe, effective practice, patient-centered care, timely, that reducing wait and sometimes harmful delays, efficient, avoiding waste, and energy, and equitable, that's providing with not vary in quality because of personal characteristic. Next. I remind you about Swiss cheese model. In Swiss cheese model, that conclude that one event of adverse event cannot done by a single event. Yeah, the event may be influenced by many factors that from the human factors, the institutional factors, and external factors. So it is responsibility for manager to understand staff performance and pressures that may be forcing individual to perform in this space. Next, please. Patient safety problem can be categorized by communication, patient management, and clinical performance. By communications, it means communication between patient and patient proxy, means caregiver and practitioners, or practitioners and non-medical staff, or among practitioners. And for patient management, improper delegations, failure in tracking, wrong referral, or wrong use of resources. And for clinical performance, happen before, during, and after treatment. Next, please. Yeah, error in healthcare I've been mentioned before. Error defined as the failure of a planned action to be completed as intended, of the uses of a wrong plan to achieve an aim. It divided into two kinds of errors: commission, doing something wrong, and omission, failing to do the right things. And the kind of error, we can name it adverse event, preventable adverse event, potential adverse event. So for adverse event, we can call the simple name is injury, and become, which is can harm or not harm. Preventable adverse event and potential adverse event when the error potential harm and intercept before to reach the patients. Ibu Neni, can you still hear my question, my voice?
Yes, Bu Alen. Oke. Ya.
Oke, Bu. Oke.
Ya, soalnya azan di sini keras sekali.
Enggak.
Oke.
Samar-samar aja kok. Oke.
Oke. Next, Pak Rudi. Ya. Rasmussen divided error into three kind of errors: skill-based mistakes, rule-based mistakes, and knowledge-based mistake. It means that maybe one error can be influenced by skills and knowledge factors, something like that, or rule factors or rule-based mistakes influence skills, also knowledge mistakes. Next, Pak. So medication error, we know in 4 types: ordering or prescribing, more precision involved in this error. Transcribing, this is pharmacist roles. The most is pharmacist role. Dispensing, the pharmacist role too. And the administrations is most of errors comes to nurse. Medication error in pediatrics is around 5.7% of all order, impact 55% of admitted patients, and potential adverse event only 1.1%. So means that medication error is prevented, and preventable adverse event only very small event. Next, Pak. This wheels is describe categorizing medication error. The blue one, category A, and the green one, category I. The blue one is no error at all. The orange one, B, C, and D is error but no harms. And categorize E until H is error and harms. For example, in categorize E, an error occur that may have contributed to resulted in temporary harm to the patient and required intervention. So this yellow one is needs another intervention for the patients. Next, Pak. Yeah, this is basic reason why we need the patient safety on pediatric care. Pediatric patient may be particularly vulnerable to medication errors due to the need for weight-based dosing, with weight ranging less than 1 kilo, such as in a premature baby, to more than 100 kilos for adolescent with obesity. Medication formulated and packaged primarily for adult dosing, lack of pediatric specific indication, healthcare setting primarily built around the needs of adult and immature hepatic and renal function in newborn. Child have a higher rate of prescription error too, and child limited communication skills to explain to communicate the pain or the experience, and wild trains of vital signs in pediatrics, such as newborn heart rate must be more than 135, and 14 ager that 135 is increase or tachycardia. Next, Pak. For oncology patient, dosing error of chemotherapy drug because of narrow therapeutic index. Yeah, research by Ring 2007 find that 310 pediatric chemo error, 85% reach the patients. So patient have the error medications, and 16 required additional monitoring or therapeutic interventions. This is already the yellow category. Varying dosage rules, modification for specific side effect may be vary during different treatment phase, and risk of infection, increasing the use of implanted central venous catheter is also making put the children into a risk of safety. Fixed tablet size make it difficulty in achieving child appropriate dosings. This is the research by Carnegie and friends about remission induction therapy, and there are medication error happen. So 57.5 children with ILL on induction treatment and involve 16.5 of chemotherapy orders. Only 3.7% of ME with were intercept. It means near miss, and 12.2% of children had adverse drug errors related overdose. It means wrong calculations about the drug, and recommendations for this situation. Measures are required to prevent calculation error in prescription, as well training to the nursing staff to intercept MA or medical errors. This is the study from Rotagi and friends. errors happen in tertiary care institutions, and we can see that for patients with a kind of cancer, the leukemia is the highest errors, and for the professional, the pharmacy is the highest errors to pharmacy, and nurses 20 the least for the nurses error, and for the category of error, 44% is category B. Category B, the yellow, the orange one, and 24% was category C, yellow, that needs more interventions. In prescribing errors, this is comes to physician, yeah, and nurses 16% administration error, means that wrong time, wrong number, wrong patient, wrong name, yeah, and 1 in 3 dispensing error is 32%, is quite a lot, and 1 in 10 transcription error is 11%, and 1 in 6 prescription error is 17%, means that since prescription error done by physician or doctor get almost 20%, yeah, 17%. Next, Pak. Yeah, next, Pak. This is the prevalency of error. Next, Pak.
Lihat, Bu.
Yeah. This is a very shocking data that for BMT and non-BMT patient, they were 2.8 and 2.5 error respectively. So patient with bone marrow transplantation and non-bone marrow transplantation is similar to get error. Next, Pak. Nah, factors may influence medication errors is healthcare professionals, the staff, patient, work environment, means the organizations, medicine, the drug, task, job desk of healthcare professionals, computerized information systems like SIMS, SIM-RS in hospital, and primary secondary care interface. This is the sample of factor associated. We saw in factor associated with healthcare professional, such as lack of therapeutic training, inadequate drug knowledge and experience, inadequate knowledge of the patient, inadequate perception of risk, overwork or fatigue healthcare professional, such as rotation, long hours of rotations or double rotations, and physical and emotional health issues, and poor communication between healthcare and patients. And we can see in related tasks, repeated system for ordering, processing, and authorization, and patient monitoring dependent on practice, patient, and other professional setting. Related to the task. Jadi pekerjaan yang sifatnya otomatisasi dan mengulang-ulang cenderung mengurangi kewaspadaan kita. Next, Pak. Ya, this is
mohon Ibu Bapak di mute yang belum di mute.
Faktor associated with computerized information system. Jadi meskipun telah dilakukan komputerisasi, masih banyak kejadian error yang terjadi because of difficult process for generating for first prescription. Ya, kemudian difficult process of generating correct repeat prescription, lack of accuracy of patient record, maybe the wrong number of medical record, maybe the birth of date, the inadequate design of laws to for human error means that this computer is not protect to the error, so it's sensitive to change the data. Next, Pak. Yeah, this is a factor contributing to human errors. Yeah, fatigue, lack of sleep, yeah, illness, yeah, drug or alcohol, boredom, frustrations, fear, stress, reliance or vigilance, ya, reliance or vigilance on vigilance ini mengandalkan orang lain, ya, interruption and distraction, ya, preparing the administration of drugs when you did in the corridor, yeah, you will be ready for interruption anytime. So it's very dangerous. Noise, heat, clutter, motion, and others. Next, Pak. Yeah. When we talk about errors, medication errors, it comes to latent failure when the system is not adequate, or active failure when the direct contact with the patient. Organization system failure is quite similar with latent failure, that indirect failure, but the organization set up the policy, the regulation, the standard that makes the active failure happen. Technical failure means indirect failure to facilities or external resources, such as broken infus pump is technical failure. When willing the cause, including failure to follow standard operating procedure, this is human errors, poor leaderships, breakdown in communication or teamwork, overlooking or ignoring individual fallibility, and losing track of objective. Then the impact of errors is many, and most of them is negative impact, such as organization maybe have to find something for compensation because of errors, and for the patients, also the hospitalization, they have to serve the prolonged hospitalization for patient, and for patients exposure to the infection, to the procedure, many procedure that unplanned before, and physical also more fatigue, more pain, and complications. Psychosocial, such as sad, anxiety, and feel isolation in social impact. Next, Pak. So patient safety climate, what kind of patient safety climate? Patient safety practice, procedure, policy, and the action of leaders and peers related to patient safety, and shared by members and giving a group, yeah, in unit, department, profession, and organizations. This 10 patient safety goal from Joint Commission that we as a nurse should be remind every second day, like identify patient danger and risk, identify patient correctly, yeah, ask patient with name and date of birth, and using the bracelet. Improve communication such as getting tests result to the correct person quickly. Prevent infections. Prevent mistakes in surgery. Use a device alarm. Use medication correctly and safely, including the tetesan infus. Label all medication. Take extra with patients. Receive anticoagulants and chemotherapy, and prevent nosocomial infections. Yeah, framework for preventing error, we can divide it into four key important keys: teamwork and communications, addressing human error, patient and family engagement, and responding to an event. In communication, we can use S-bar, S-bar. Each of health professional using S-bar for communications. Next, Pak.
Miss Allen, you have still 5 minutes.
5 minutes.
Yes.
Okay. Thank you. Can I jump to the slide, which is chemotherapy? Chemotherapy. Next. Yeah. Yeah, chemotherapy administration standard and guideline. Facts that oncology is challenging field and high stakes and vulnerable patients. Chemotherapy has narrow margin of error, and chemotherapy is toxic event of therapeutic doses, and regimen are often highly complex, and administration is multidisciplinary process. The goal is error reductions and safety. Next, Pak. Next. Yeah, this is the steps, the chemotherapy from the plan of prescribing until monitoring chemotherapy. The cause of medication error, this is communication defect, information gap, confusion related drug names, competency and education staff. So for the chemotherapy administration, we suggest to nurses who are responsible for chemotherapy to be certificate first. Next, Pak. Next. Yeah, this is related technology, how to keep the patient safety and protect patients. Avoid handwritten order. Yeah, even combination handwritten order is limited, and barcode scanning technology is recommended. Barcode verification prevent wrong patients and prevent medication mix up at the point of administration, and prevent look-alike sounds alike drug errors. Next, Pak. This is nursing accountability related to drug administration. Nurses verify order and patient-specific element prior to drug administration. Double check with independent nurse, 2 nurses. Compare pharmacy product to the original order and assess the medication integrity. Assess the patient previous chemotherapy-related toxicity. Confirm treatment plans of the days. Consult patient unexpected toxicity management symptom. Next, Pak. Next, Pak. One more. Yeah, this is nurses adherence. Adherence since start from know the plan of chemotherapy regimen until nurse can stick in the standard, in the regulation, in the guideline. Next. Patient and family involvement is very important in chemotherapy session. Patient and family can play an integral part in medication use process. Patient and family receive important information and avoid medical jargon using picture is suggestion and doing repeated educations. And patient and family as a dynamic role, academic team can work together, collaboration with the health professional and nurses, and patient should have keep the record for all medication, include missed dose and side effect. Next. Based on the research by Davis et al., patient satisfaction were cheerful of practice with time, short waiting time, highest patient satisfaction. For the lowest patient satisfaction, when they get clinic on phone and information about delay and waiting time at clinic that very long. So this is we can see that, and we can cut the low satisfaction here and move to the highest satisfaction. Next, Pak. More to slide ya Bu Nani. Culture of safety is important. So when we all staff, medical and non-medical staff aware about the safety, so we can build the culture safety. So the organization can build safety of culture. Then empower the leadership, has prioritized the safety, create the environment, and use this process can be openly discussed and promote inclusion of frontline staff and include the participant of patient and family. Next. The three model of safety culture is 3E, enabling, enacting, elaborate. Enabling means leader enable safer practice through directing attention to safety and creating context, enacting frontline staff enact and safety culture, and elaborate means leaders and staff implement practice together. Next slide. So the conclusion, we have to apply root cause analysis and FMEA consistently to get and to prevent safety non-safety practice. I mean, train and build safety culture and strengthen multidisciplinary team to establish patient safety culture and leader in quality improvement, focus on input, process, and outcome. And quality improvement, cycle-based medication safety. Next, Pak. Yeah, thank you very much. Let me give a little bit info that Faculty of Nursing Universitas Indonesia opened the program of Magister Nursing for oncology. So please come to Universitas Indonesia. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Bu Nani.
Waalaikumsalam warahmatullahi wabarakatuh.
Warahmatullahi wabarakatuh.
Terima kasih Bu Alen, sangat luar biasa presentasinya dan komprehensif, sampai slide-nya disiapkan banyak, tetapi karena waktu yang tidak memungkinkan, jadi nanti mungkin dibahas di diskusi ya. Thanks to Dr. Alenia Dekania who has presentation excellent, material and comprehensive ya. Di situ banyak sekali bagaimana peran perawat di dalam di sini memang menekankan dari kasus itu banyak terjadi kesalahan di dalam medication error yang dari persiapan, pencampuran dan pemberian ya tadi memang banyak sekali dan peran perawat sangat berperan banget terhadap safety di situ. Kemudian yang tidak kalah penting adalah sesi yang kedua ini yang mungkin menjawab dari beberapa pertanyaan yang di sesi pertama mengenai apa itu closed system. Inilah ahlinya Bapak M. Nafis Ghazali yang akan memberikan tuntas mengenai closed system. Di mana closed system ini adalah Sobat Nurse Himponi adalah salah satu produk, ya. Maksudnya salah satu alat untuk bagaimana meminimalis daripada medical error. Dan selain itu juga membuat safety buat siapa? Safety buat pasien dan safety buat petugas, terutama perawat ya. Memang kalau bicara safety pasti berhubungan dengan macam-macam lah. Tadi apakah pasti terkait dengan biaya dan sebagainya. Tetapi kalau kita lihat bagaimana tadi yang dipaparkan oleh Bu Alen sangat besar sekali di dalam kita melakukan safety di awal ya di dalam kita merawat pada pasien kanker. Mungkin sebelumnya akan saya bacakan CV dari M. Nafis Ghazali. Beliau sekarang memang bekerja di Brown ya. Kemudian juga kalau usianya sih masih muda ya. Itu bisa kita lihat bahwa lahir di Jakarta ya. Kemudian beliau juga seorang apoteker, sebelumnya juga punya pengalaman di rumah sakit, tetapi sekarang bekerja di PT Bibron khususnya untuk pengembangan terhadap closed system. Mungkin itu ya CV singkat dari Nafis Ghazali. Waktu dan tempat kami persilahkan. Silakan Pak Nafis. Oh iya, sebelumnya kami sampaikan tadi teman-teman nurse sobat Darmais, nurse sobat Himponi dapat menuliskan di chat bila ada yang mau ditanyakan atau diklarifikasi terhadap materi Bu Alen. Tapi nanti dijawabnya setelah Pak Nafis memaparkan materi yang kedua ini. Silakan Pak Nafis.
Oke. Terima kasih Ibu Nani atas waktu dan kesempatannya. So I would like to start now. Good afternoon, everyone. Can you hear my voice clearly, Bu Nani?
Clear.
Okay, thank you. Okay, good afternoon, everyone. Assalamualaikum warahmatullahi wabarakatuh. Welcome to International Webinar Himponi. First of all, I would like to thank you to Ibu Nani as our moderator and head of Himponi, absolutely, especially for Ibu Kamalarita for the opportunity for Bibron for presentation today. In this session, I would like to present about the Bibron system infusion therapy in oncology. Okay, let's start. So, what's the chemotherapy drugs? Chemotherapy drugs is that work with stopping or inhibiting the growth of cancer cells that the split up rapidly. And then, so chemotherapy is the type of treatment used to destroy cancer cells that are harmful to the body. Okay, and then this is for chemotherapy drugs have the following characteristic. The characteristic allow is carcinogen, mutagen, teratogen, reproductive toxicity, genotoxic, and organ toxicity. So it's very dangerous for us, especially for HCPs or healthcare professionals if they are exposed to chemotherapy drugs. And then what's the mechanism of exposure to chemotherapy drugs? This is the potential routes of exposure. First, through dermal absorption, direct drug contact, contact with contaminated surfaces, contact contaminated with body fluid when the through leaking from the container, spills on mixing table surface, patient beds, treatment room, floor, mixing container. And then the next is injection, like sharp injuries, needle stick injury, breakage, and breakage. And then for ingestion via contaminate from the food and germ, hand to mouth transfer, and then inhalation, aerosol, and vaporize. Okay, based on scientific evidence, this is the data for the most common clinical risks to healthcare workers associated with infusion therapy. Like the first is needle stick injury. We can see the number is 1 million SIs per year in Europe, with comorbid around more than 8,000 healthcare workers can cause as HIV or hepatitis, like that, something like that. And then for chemical contamination, we have around 8 million healthcare workers in the US, I think, are exposed to hazardous drugs. Contamination can happen during preparation, transportation, administration, and disposal of chemotherapy drugs. And 1 in 5 nurses who handle of chemo drugs lost their pregnancies. So it's very, very carefully about the chemotherapy drugs. And then there is to the patient, I think the first is air embolism. 2 until 3 ml are into the cerebral circulation, can be fatal. And then the just only 0.5 until 1 ml of air in the pulmonary vein can cause cardiac arrest. And then with the next is microbiological contamination. Many patient was passed away, around 16 million per year due to microbiological contamination, with the very high cost for the microbiological contamination if in the hospital. So it's can be reduced until 50% with hand hygiene properly. And then the particle contamination, that next is around 1.5 micron. A particle was size of only can cause blockage of in the patient. So in the study case, conduct on nurses' urine sample who provide chemotherapy on patient, we found around 40% in the urine contain of chemotherapy drugs. So it's very, very much, almost 40%. And then this is for the estimated cost treatment for hospital personnel with cancer is quite high. And then maybe our participant hear about there was report death because of chemical contamination in drugs preparation area of pharmacy department of the hospital Lavi, causing cancer of oncology nurse. So this is happen in oncology. So, and how about current situation in a hospital, especially in our country in Indonesia? We can see the administered drug in the hospital, especially in the pharmacies, they still use syringe with needle, and then ray spiking in the infusion therapy in the ward, and administered with a needle too. And then this is very important related the disposal chemotherapy drugs. We must to manage this disposal of chemotherapy in oncology. So, and then we need new ways or concept in chemotherapy drugs management to prevent the risk. to prevent microbial contamination, particulate contamination, chemical contamination, sharp injury, DHP, and others, and etc. So we need, according the Journal of Oncology Pharmacy Practice, with closed system and needle-free, it will increase safety of infusion therapy, especially for chemotherapy. With the closed system, we can, without any exchange of air between the infusion therapy system and the environment. So as well as from the environment to the infusion therapy system. So this is can block the microbiological can jump into the system of infusion therapy. So total safe infusion therapy or total safe in chemotherapy, safety from the drug of preparation in the pharmacies, in the pharmacy department, and then the administration in the oncology ward, and also until disposal, chemotherapy drugs, safety for janitor. So this is for it's must for total safe infusion therapy in oncology. We're starting from the selection of IV container. The name is Ecosol. I think all of you of participants, you know the Ecosol, ecological solution. This is for IV solution coming from Bibron. It's local product with German quality. The container must be strong and deflate perfectly, inert with all chemotherapy drugs, and also a robust container material. The use of needle-free closed system and drug mixer devices and closed system absolutely must be collapsibility for maximize for the dosage of the drugs. And then mostly the chemotherapy drugs are given by infusion. For that, we need safe access to patient blood vessels. With the safety feature in the IV catheter, the chemotherapy process will increase the safety and comfort for patient and others who give chemotherapy. So as well as with selection of size, giving officers of the flexibility to choose according the condition of the patient who will undergoing chemotherapy to prevent extravasation by catheterization. Okay, the next is the following are product used for drug admixture activity in the pharmacy. This is a rule for the pharmacies for drug administration for the drugs, oncology especially. This is the medical devices, the closed system, and also absolutely needle-free. So we cannot see the needle in here for administer the drugs. Then the combination cytosets, infusion, and then cytosate mix will form a closed system during the preparation, application, and disposal of chemotherapy drugs. So this product of these medical devices, the role of use in the pharmacies, we can see in the picture. The pharmacies use a cytosate mix for the drug, for administer the oncology drugs. You can see like that, like this. After this slide, I would like to share about the video related this product. So don't worry, you must be more know about this product. And then how to handling for the cytosate mix. This is a rule for the pharmacies. First, we priming for the cytosate mix, and then add the drug, oncology drug, and then the will injection and aspiration for several times to shake it the product, shake it this solution with the oncology drugs, and then we can get the product like this, and then we can share after this finish in this in the pharmacist department. After that, we can deliver to in the word oncology, so oncology word, I think. Okay. The next stage is application. This rule for the nurse. Drug application is an important and sensitive step in infusion therapy. The complexity of this phase expose health worker of patient to various risks. In order to reduce the risk of contamination, the full range of Bibron product create a closed system and offer convenient solution for the severe administration and cytotoxic drug by infusion or bolus. So for the safe administration of chemotherapy drugs with more than one drug regimen, in the nursing world, we use combination of cytosat infusion with cytosat mixed closed system and safety administration in the world. This is previously I already tell about how to press admixture in the pharmacies. This is the product finish, and then move to the word, and then the word connect with a cytosat infusion. Okay, this is make a closed system and needle free. This is the video for the cytosat mix and infusion. We can see the first is priming for cytosat infusion. We can see this is the liquid of solution. This is for basic solution, I think. This is not contained for the drugs. Not yet, but after that, sealing with a clamp. After that, open the injection pot and add the drugs coming from outside. Use the syringe. So this is a lower lock connection, more safety. This is, you can see, this is a safety valve, needle free. But the drugs we can see close into the bottle and withdrawal and injection and withdraw injection. After that, we can remove for the syringe. And then next step is close with combi stopperette. Okay, after that, finish in the pharmacies, delivered to the ward of oncology. Open the connection for cytosat mix and cytosat infusion between, and then connect. We can see this is a valve. So we need to connect with other product and click. So this connect, close, it's locked, and then open the clamp and the drugs will run out to the cytosat infusion coming from cytosat mix until very the end. And then this is for cytosat infusion also have a air stop also, I think, to stop the liquid or the drugs come to makes the empty the tubing. So that's how to closed system works, coming from cytosat infusion and cytosat mix. Okay, and next for the all of our product for cytosat or infusion for especially for oncology, the differentiation between the cytosat infusion for a non-toxic drug is in the material of tubing. The material of tubing for our product for oncology is neutrapur or polyethylene. With the AHP free, it's compatible for toxic drug such as chemotherapy. So this is related safety issue related the AHP and PVC, I think. And then this is for the others product. Previously, the cytosat infusion and the cytosat mix we use for more than one regimen. How about the only one regimen if we would like to chemotherapy to the patient. We also can use intravitreal sepsis Neutrapur and Intrapur inline. It's also the material tubing is non-PVC. It's material tubing Neutrapur. Also same with cytosol infusion and cytosol mix. So okay, this is we also have infusion set for light protect. Commonly in the drug of chemotherapy have drug should be prevent from coming from the light. So this is we have a portfolio product too to use for light protect drugs. For light protect, so your protection until very the end. This is the last but not least my slide to protect against exposure for chemotherapy drugs with closed system and needle-free product are needed to avoid risk from start until the end of the therapy. Also for the important thing in the disposal. So Bibron infusion therapy consistent number of different therapies use drug in liquid solution format for the patient to support recovery therapy. Apart from the pharmaceutical Bibron offer whole portfolio product for infusion therapy process with patient access, medical devices for safe drug preparation until the end, as well as material as gravity on infusion infused pump. We already have it. So all participants and Bu Nani, that's all my presentation. Thank you for the opportunity, and I will come back to you, Ibu Nani. Thank you very much for your attention.
Okay, thank you, Mr. Ghazali.
Nafis, Bu.
Nafis dong. Aku senangnya Ghazali deh.
Nafis, kalau Ibu Sunda, Najis. Napis. Okay, Bu, please, Bu, silakan.
Thanks to Mr. Nafis, your presentation very clear and informative to use closed system for safety chemotherapy drug ya. Jadi teman-teman tadi yang bingung dan sebagainya bisa mungkin bisa menjawab dari kegalauan yang tadi mengenai closed system.
Amin.
Ya, sekarang sudah 2 presentasi sudah tampil. Mungkin ini adalah seksi diskusi, mungkin ada teman-teman yang akan mengklarifikasi atau memperjelas dari apa yang disampaikan oleh 2 narasumber siang ini. Bisa dituliskan di kolom chat atau ada yang raise hand untuk bertanya langsung kepada kedua narasumber yang luar biasa di siang ini. Mungkin yang di chat bisa ditampilkan Pak Rudi, mungkin ada pertanyaan.
Yang raise hand dulu Bu, tadi takutnya.
Oh mau raise hand, oke. Ini kalau raise hand ada Ermalawati sama Rahmawati ya?
Rahmawati.
Bisa dibuka videonya dan bisa menanyakan langsung kepada narasumber kita, yaitu Pak Nafis dan Bu Alen. Silahkan.
Pak Nafis bisa stop.
Oh ya, Pak Nafis stop share dulu. Ya. Silakan, tadi ini yang raise hand ada Bu Irmalawati dan Rahmawati. Rahmawati dari Rumah Sakit Darmais nih. Apakah ingin menanyakan langsung kepada 2 narasumber? Silakan. Silakan. Tidak ada. Mungkin Bu Erma. Atau salah pencet kali ya? Mungkin kita bisa sambil menunggu bila ada teman-teman yang akan menanyakan secara langsung kepada Bu Alen dengan Pak Nafis. Mungkin ada di sini yang di kolom chat yang ditujukan kepada
Nani, boleh saya pancing Bu Nani?
Di kolom chat.
Di chat ini ada dari M. Saiful Rahman, izin bertanya. Nah, ini mungkin ditujukan kepada Bu Alen, bisa dijelaskan, dicontohkan mengenai RCA dan FMA yang konsisten. Kemudian sama juga dari M. Saiful Rahman mengenai bagaimana bisa dijelaskan mengenai training terapeutik dalam healthcare profesional. Silakan Bu Alen.
Ya, terima kasih Bu Nani. Dalam bahasa Indonesia aja ya, biar itunya istilah-istilahnya sesuai ya dengan sehari-hari. Ya, terima kasih Pak Saiful Rahman. Untuk pertanyaan yang pertama, bagaimana menerapkan RCA dan FMEA yang konsisten. Yang pertama, rumah sakit harus punya tim mutu dulu dan tim keselamatan pasien rumah sakit. Itu dulu harus dibentuk. Ya, jadi ada leader, ada job desk-nya, kemudian ada anggotanya. Yang kedua, tugas dari tim itu sebenarnya ada dua. Niatnya sih harusnya mencegah kejadian cedera. Ya, niatnya harusnya mencegah kejadian cedera. Jadi dilakukan risk management. Tapi seringkali karena kejadian pelayanan kesehatan itu sangat dinamis dan sangat sering, ya, variabelnya terlalu banyak, kita kadang belum sempat duduk bersama untuk memikirkan pelayanan apa yang bisa dicegah ya gitu. Ternyata udah ada kejadian. Nah, kejadian itu harus kita atau insiden ya, kita tetapkan dulu ini kejadian nyaris cedera atau yang kejadian tidak diharapkan. Kalau kejadian nyaris cedera berarti pasiennya tidak mendapatkan pelayanan yang salah tadi, yang tidak safe. Tapi kalau KTD yang tidak diharapkan itu bisa dua hasilnya. Bisa pasiennya tidak apa-apa, bisa pasiennya parah atau sampai meninggal gitu KTD-nya. Nah, berarti harus ditangani segera. Jika ada kejadian tersebut, maka harus dilaporkan kejadiannya dalam maksimal 2 kali 24 jam. Kenapa? Karena daya ingat seseorang itu kalau sudah berhari kemudian sudah sibuk dengan kejadian kegiatan yang lainnya, biasanya daya ingatnya itu akan menurun. Ya, sehingga paling cepat itu laporan kejadian harus paling lama itu harus 2 kali 24 jam. Kemudian kita laporkan ke tim ke atasan langsung, dan atasan langsung melaporkan ke tim keselamatan pasien rumah sakit. Nah, tim keselamatan rumah sakit ini melakukan grading matriks ya. Jadi nanti Bapak bisa lihat grading matriks untuk keselamatan pasien itu seperti apa. Kalau warnanya biru atau hijau itu investigasinya sederhana. Jadi karena tadi kejadian tidak diharapkannya itu kejadian nyaris cedera, ya. Dan rekomendasi yang diberikan itu misalnya tingkatkan kewaspadaan, ya, berupa rekomendasi ikuti guideline dan sebagainya. Jika gradingnya berwarna kuning atau merah, itu udah warning, udah bahaya, sehingga dilakukan root cause analysis. Nah, root cause analysis ini dilakukan oleh tim keselamatan pasien rumah sakit ini dengan melakukan pertanyaan investigasi, ya, melakukan bertanya 5 why minimal, ya, minimal 5 why. Kenapa bisa terjadi salah suntik? Oh, lampunya gelap. Kenapa lampu tidak diterangi? Kenapa lampu gelap? Gitu. Jadi dari jawaban yang pertama itu dicecer istilahnya, dikejar sampai yang bertanya itu, yang menjawab itu tidak bisa lagi mendapatkan jawaban lain. Nah, dari situ tim RSCA ini kemudian membuat laporan dan membuat resume untuk pembelajaran. Apa hal-hal yang harus dilakukan? Action-nya kalau berhubungan dengan maka kita harus laporkan ke direktur, ya, tindakan-tindakan apa saja yang harus dilakukan oleh pihak rumah sakit. Kalau sampai kepada misalnya kalau pasien menuntut sampai ke pengadilan, berarti itu yang melakukan adalah pihak rumah sakit dan bagian hukum dari rumah sakit untuk memprosesnya. Kemudian laporan tidak berhenti di rumah sakit, tapi sampai ke Komite Keselamatan Pasien di Persi ini untuk rekaman secara yang mereka dapatkan supaya dia dapat versi global dari laporan seluruh rumah sakit. Nah, laporan yang tadi dibuat juga diberikan ke unit. Unit ini untuk pemberitahuan sekaligus untuk memberikan warning kalau kejadian ini nggak boleh terulang, gitu ya. Nah, apa ininya FMEA tadi? Failure mode analysis. Failure mode analysis adalah usaha-usaha yang dilakukan, yang diidentifikasi oleh tim dalam hal kalau kejadian seperti ini, faktor input apa yang harus disiapkan, ya. Dari misalnya failure mode analisisnya adalah menganalisis, namanya juga menganalisis ya, menganalisis efek. Kalau misalnya tadi ternyata salah mengambil obat, ya tadinya harusnya obat A karena look alike, hampir sama, jadinya ngambilnya vitamin, misalnya seperti itu, ya. Jadinya ngambilnya vitamin, sehingga dari tim keselamatan pasien itu mengkaji apakah sudah ada guideline atau standar dari penyimpanan obat-obat. Misalnya apakah penyimpanan obat-obat di ruangan dipisahkan antara yang generik, yang labelnya merah itu dipisahkan dari jangkauan, seperti itu. Apakah ada pencatatan setiap kali pengambilan obat? Kemudian apakah ada sistem komunikasi antar tenaga kesehatan, termasuk double check, ya, double check. Jadi ini pesan buat teman-teman semua, kalau kita dimintai tolong untuk hadir sebagai orang yang dimintai double check, itu wajib mau. Jadi bukan mau nggak mau, tapi wajib mau. Ya, karena tadi kita memikirkan supaya kehilafan satu teman ini jangan sampai dibiarkan, ya. Jadi double check ini gunanya untuk mengcounter, ya, mengcounter. Oh, ini salah nih kodenya, ini angka 8 nih, bukan angka 5, misal seperti itu. Itu sangat penting. Kemudian dari failure mode tadi udah dianalisis, maka tim juga memikirkan langkah-langkah atau intervensi untuk menyelesaikan masalah tadi, ya. Seperti itu Pak Rohman kira-kira, dan kegiatan itu dalam siklus tim penjaminan mutu itu bisa dilakukan baik untuk fokus ke pencegahan, ya, jangan sampai kejadian itu terjadi lagi, atau pada saat insiden sudah ada. Demikian Bu Nani, jawaban yang kedua ya?
Ya, yang kedua yang belum terjawab Bu Alen.
Oke. Yang kedua, bagaimana untuk training terapeutik? Terapeutik sendiri ini adalah istilah asuhan yang terapeutik, asuhan yang bukan hanya terampil, tapi juga ada caring di dalamnya, seperti itu. Jadi training terapeutik ini bisa luas, bisa spesifik. Ya, kalau luas misalnya prinsip caring secara umum, tapi kalau misalnya sempit khusus onkologi, berarti teman-teman di sini sebaiknya ikut sertifikasi untuk keperawatan dasar dari onkologi yang diadakan oleh Himponi. Demikian.
Terima kasih Bu Alen, sangat komprehensif. Mungkin nanti Pak Rahman bisa menjawab, sepertinya Bu Alen menjelaskan dengan tuntas, ya. Mungkin ada pertanyaan lagi yang lain, Pak Rudi, coba di-share. Oh, di sini apakah, kayaknya ada kelanjutannya deh, Pak Rudi, pertanyaan dari Grace. apakah ini ditujukan kepada Bapak Nafis ya, apakah ada sediaan ekosol 250? Kemudian kayaknya ada pertanyaan berikutnya nggak, Pak?
Izin yang raise hand, Bu Nani.
Oh iya, ini dulu dia yang raise hand. Oh ya, nanti dulu nih mungkin dia untuk Pak Nafis tadi pertanyaannya apakah ada sediaan untuk ekosol tadi yang disampaikan oleh Linda May ya, dari Grace.
Ya, Ibu, terkait dengan sediaan 250 mili, untuk saat ini sudah discontinue, Bu. Terakhir tahun 2019, itu dulu sebelumnya kita memang tersedia 250 mili, tapi karena satu lain hal dan mungkin juga karena permintaannya sedikit, jadi discontinue sekarang.
Oh ya, itu informasi ya Bu Grace. Nah mungkin yang raise hand di sini ada, saya lihat ada beberapa tadi ada yang rame-rame siapa nih? Oh ada Lina Hasriati, silakan Lina Hasriati untuk menyampaikan pertanyaannya kepada ditujukan kepada siapa dan sebutkan dari mana nama dan dari mana asal instansi. Silakan Bu Lina.
Baik, terima kasih Bu. Mohon izin.
Bisa buka kamera, Bu Lina.
Ya, mohon izin mau minta maaf sedang tidak dalam kondisi bisa on cam Bu.
Oh ya, silakan.
Iya, pertanyaan pertama saya tujukan untuk Bu Alen. Bu Alen, mohon membagi sedikit tips-tips bagaimana cara RCA ataupun ketika fase investigasi itu agar tidak tidak terkesan blaming Bu. Soalnya seringkali kami di lapangan itu memotivasi teman-teman yang mengalami insiden untuk membuat laporan insiden itu mereka ketakutan karena khawatir blaming. Mungkin Ibu punya tips-tips supaya tim komite mutu ketika sedang melakukan investigasi atau melakukan RCO-nya tidak terkesan blaming sehingga menakutkan. Kemudian pertanyaan kedua, soalnya kita pengalaman ya Bu Nani, sering banget tuh ya di meja RCA. Kemudian pertanyaan kedua untuk Mas Nafis ya, Mas Nafis, alhamdulillah Rumah Sakit Darmais itu beberapa ruangan khusus kemoterapi sudah menggunakan closed system dan itu bagus banget ya. Sayangnya saya nggak tahu alasan apa, apakah karena harganya memang mahal, nggak covered oleh government insurance sehingga tidak semua ruangan kami menggunakan closed system padahal safety-nya tuh bagus banget, terutama kalau di ruang rawat inap seperti di ruangan saya, itu pasien kemoterapi kadang sampai 5-7 hari, jadi tidak one day kemoterapi. Sehingga kemo itu memang terus-menerus berjalan 24 jam selama 5 hari atau kadang 7 hari. Pertanyaan saya, jika kami menggunakan closed system yang tadi itu yang cabangnya banyak banget tuh Mas Nafis, apakah nanti setelah setiap hari selesai kemo, botol kemo itu kami lepas, karena kan cabangnya sepertinya tidak bisa dilepas ya, atau tetap tergantung per hari sehingga ketika hari ke-7 botol kemo ada 7 yang sudah selesai digunakan. Karena ini sangat terkait dengan insiden resiko jatuh pasien kami juga ketika dia harus ke kamar mandi, ke toilet dan sebagainya. Mohon penjelasannya sedikit Mas Nafis. Itu aja Bu Nani, terima kasih.
Terima kasih Bu Lina. Ini Bu Lina ini memang perawat di Rumah Sakit Darmais. Mungkin Pak Nafis juga kenal, apalagi Bu Alen kenal banget ini mahasiswanya. Jadi mohon dijawab tadi Bu Alen mengenai tip-tip bagaimana supaya tidak terjadi blame culture. Silakan Bu Alen.
Terima kasih pertanyaannya Bu Lina. Tips bagaimana menghindari blame culture. Ya, itu sangat psikologis ya. Kalau kita melakukan kesalahan itu sangat psikologis kalau kita jadinya merasa lebih bersalah. Dan pada saat kita ditanya untuk mempertanggungjawabkan apa yang kita lakukan, kita makin bersalah lagi, jadi 2 kali. Jadi udah bersalah ke diri sendiri, kemudian disaksikan dengan penanya tadi, tim keselamatan pasien itu bertanya lebih detail ya, seperti menginvestigasi seperti Pak Polisi gitu ya. motif apa sampai begitu ya. Ya harusnya sih nggak sampai pakai motif ya, kita nggak punya niat sama sekali ya. Kecelakaan namanya juga kecelakaan. Nah, tipsnya apa? Kalau di health profesional, di tim kesehatan, mereka sebagai pelaksana, mereka akan melaksanakan apa yang digariskan oleh organisasi. Jadi organisasi dulu yang menunjukkan bahwa mereka tuh friendly dalam RCA, RCA. Itu friendly, bertanya tidak menyalahkan, kemudian mereka harusnya punya kode etik dalam bertanya juga, ya. Karena posisi salah aja udah kebawa mimpi untuk diri sendiri nih, belum ngaku aja udah kebawa mimpi. Apalagi ini harus ngaku, ya. Dengan sikap dari tim keselamatan rumah sakit yang friendly, itu sebenarnya memudahkan mereka untuk mendapatkan data-data yang lebih sensitif ya, yang bisa ditingkatkan dengan untuk peningkatan mutu, jadi pembelajaran ya, dan bisa dijadikan usaha-usaha untuk peningkatan mutu ke depan gitu Bu. Jadi balik lagi tadi rasa takut, rasa bersalah itu wajar sebagai manusia yang salah. Tapi organisasi kalau dia fokusnya udah safety culture, harusnya juga kelihatan dari sikap-sikap mereka pada saat menggali data. Jadi bukan blame culture, bukan menyalahkan, bukan ingat ya saya ini atasan kamu. Nah, itu udah menunjukkan ada superioritas. Kemudian ada misalnya dengar-dengar orang yang di sana itu sudah dipecat gitu. Itu bagian dari safety blame culture yang dibangun oleh organisasi sebenarnya. Jadi kemampuan melapor itu tergantung dari sejauh apa rumah sakit sudah menerapkan safety culture. Demikian Bu.
Ya Bu Lina tuh pertanyaan, saya setuju banget dengan Bu Alin. Seperti itu memang. Harus ada komitmen dari atas sampai direktur puncak sampai staf bahwa blame culture itu tidak ada, dan mungkin teknik-teknik tadi yang harus dikembangkan. Makanya di Rumah Sakit Darmais itu juga melakukan improve terus terkait untuk bagaimana kita, ini tambahan aja ya, untuk mengakses sebagaimana sih budaya keselamatan kita gitu. Nah, itulah dari situ, dari survei itu bisa kelihatan di mana posisi daripada posisi dari staf di rumah sakit tersebut dan akan dilakukan tindakan apa. Nah, itu salah satu upaya-upaya. Tapi terima kasih Bu Alen atas penjelasannya. Mungkin Bu Lina juga sudah puas ya. Mungkin pertanyaan yang kedua dijawab oleh Pak Nafis terkait dengan biasa ini closed system tuh udah harganya udah masuk nggak sih di dalam BPJS, karena tahu sendiri Pak Nafis bahwa kita dalam semua pasien kita hampir di rumah sakit mungkin 80-90% adalah pasien BPJS. Dan kita lihat bahwa kasus kanker makin meningkat dan pasien-pasien sebagian besar adalah pemberian kemoterapi. Kita pengen banget loh perawatnya menggunakan closed system, tadi sudah dijelaskan, safety banget, juga mengurangi beberapa APD, tadi juga sudah dijelaskan oleh Susan bahwa tidak perlu pakai APD lengkap, tetapi sesuai dengan peruntukannya lah ya untuk safety. Nah mungkin silakan Pak Nafis perjuangannya udah sampai mana supaya harganya ditekan dan masuk di dalam BPJS.
Oke, Bu Nani, terima kasih. Dan pertanyaannya terima kasih terkait dengan closed system yang memang sudah digunakan ya di rumah sakit. Yang pertanyaan pertama terkait dengan apakah sudah masuk BPJS, tentunya untuk produk closed system ini sudah listing di katalog gitu ya. Ini bisa diorder melalui katalog, kemudian terkait dengan kenapa mahal, apakah bisa diklaim BPJS, tentunya untuk klaim BPJS untuk kemoterapi sendiri terpisah ya antara obat dan juga dengan alkes, jadinya harusnya sih bisa diklaimkan ya untuk alkesnya itu sendiri. Kemudian terkait dengan penggunaan closed system ataupun cytoset infusion dan mix yang diberikan di rawat inap, tentunya berbeda ya dengan rawat jalan seperti itu. Kalau di rawat jalan kan sekali pakai, kemudian diberikan, selesai sudah pulang, kemudian disposal selesai dalam satu kesatuan dibuang seperti itu. Berbeda dengan yang ada di rawat inap ini memang masih kita kaji gitu ya. Terakhir kita kaji dengan Ibu Retno seperti itu. Untuk di rawat inap ini seperti apa? Apakah tadi yang disampaikan apakah harus digantung botol-botolnya? Harusnya sih memang seperti itu ya. Mau tidak mau ya. Kalau tidak mau ya secara apa ya harusnya sih yang normal ataupun yang sesuai itu ya sekali pakai langsung dibuang karena kita tahu untuk produk ini kan kita mengambil fungsinya adalah dari fungsi closed system itu sendiri. Jadi kalau misalnya dibuka satu-satu lagi nanti ya sama saja dengan open system. Jadi tidak fungsi atau fitur dari closed systemnya tidak dapat kalau memang harus dibuka satu persatu. Tapi memang harus dikoneksikan sampai dengan dari pertama sampai akhir. Jadi kalaupun memang pemberian satu persatu ya memang one by one. Ya kalau misal regimen obatnya satu-satu ya kasih satu, kemudian tadi menggunakan intrapur inline atau intravik sel-sel intrapur, setelah itu dibuang, nah itu kan jadi satu saja, tidak pakai closed system atau cytosite mix atau infusion. Kalaupun memang menggunakan cytosite infusion, misalnya dalam satu hari dikasihkan 2 obat, ya setelah selesai ya mau nggak mau harus dibuang. Memang cost lagi seperti itu. Jadi memang ini nanti akan jadi coba saya diskusikan lagi dengan saya juga tentunya harus diskusi juga dengan expert-expert yang ada di khususnya di Darmais ya karena memang produk ini memang sudah sangat masif digunakan di Darmais gitu ya. Nanti mungkin saya akan coba kaji lagi terkait dengan penggunaan di rawat inap seperti apa. Begitu Ibu Nani jawabannya.
Ya, terima kasih Pak Nafis. Ada juga sih pertanyaan tadi hampir sama yang disampaikan Ibu Lina dari Fitri Saraswati dari RSKD, mungkin tidak dijawab dengan Pak Nafis. Mungkin ada yang raise hand, siapa nih? Oh, Tumiar Demak Raja Guguk. Silakan Ibu. Pertanyaannya ditanyakan kepada siapa? Ya Ibu silakan.
Iya, makasih Bu. Saya mau bertanya Bu ke Bapak Nafis. Pak Nafis ya. Gini Bu, kan saya pernah ada pasien itu pasien kemo. Nah, pada saat masuk kondisi pasien bagus. Ternyata terus itu kita kita telepon ke bagian dispensing kemo, obat bisa dioplos gitu kan Bu. Nah, ternyata itu pasien berapa jam kemudian penurunan kesadaran, sedangkan obat sudah dioplos. Nah, bagaimana kelanjutannya Bu? Apakah obat sudah dioplos, obat kemo sudah dioplos tidak bisa dipakai lagi? Sedangkan itu pasien setelah 5 hari kondisinya sudah membaik. Apakah obat kemo bisa dilanjutkan atau gimana Bu? Apakah pasien bisa kemo apa dilanjutkan dengan obat tersebut? Bisa dilanjutkan atau gimana Bu gitu Bu?
Makasih. Terima kasih Bu Tumiar, dari mana ya?
Oh, saya dari Rumah Sakit RSPAD Gatot Subroto Bu, maaf.
Dari Rumah Sakit RSPAD. Oh ya, silakan Pak Nafis.
Oke, RSPAD Ibu Reni ya berarti ya.
Oh iya Ibu
instalasi
Reni,
farmasinya.
ya Pak, ya Pak Bu Reni.
Lambat beliau kalau ketemu ya. Oke Bu, terkait dengan expired date obat, jadi memang ketentuannya seperti itu. Biasanya dapat konfirmasi dari perawatan, baru farmasi akan melakukan pencampurannya. Akan tetapi ini tiba-tiba pasiennya terjadi perburukan gitu ya. Nah, memang kalau perburukan misalnya langsung pada hari itu juga membaik, terus obatnya sudah dioplos dan expired date-nya masih memungkinkan untuk digunakan, masih bisa digunakan. Tapi ini sampai dengan 5 hari rasanya untuk obat onkologi itu maksimal biasanya itu 1 kali 24 jam ataupun 2 kali 24 jam setelah dioplos itu harus langsung digunakan dan harus habis seperti itu. Kalau memang sudah dioplos, tapi kalau misalnya belum dioplos itu masih memungkinkan ya. Itu juga tidak ditanyakan kalau misalnya belum dioplos. Ini pertanyaannya kalau sudah dioplos masih bisa digunakan enggak? Tergantung dari obatnya Bu. Tanyakan lagi ke farmasinya untuk obat tersebut ED setelah dioplos berapa lama gitu ya. Karena beberapa obat kemoterapi expired date-nya itu bermacam-macam, berbeda-beda ya. Ada yang kalau dulu saya masih di pencampuran obat itu ada yang 4 jam. 4 jam dioplos harus digunakan dan harus sudah habis ya. Jadi itu pendek sekali. Ada juga yang 1 kali 24 jam. Nah, untuk yang 5 hari rasanya sih jarang ya, atau mungkin bahkan tidak ada seperti itu. Jadi next, jika terjadi hal seperti itu lagi, bisa ditanyakan ke farmasi, bagian farmasi untuk obat tersebut, apakah expired date-nya masih memungkinkan atau tidak. Kalau misalnya tidak, ya terpaksa harus dieliminasi atau dimusnahkan obat tersebut. Seperti itu sih, Bu.
Ya.
Nggak bisa dipaksakan.
Ya, terima kasih.
Iya.
Udah jelas,
Pak Nafis, berarti pasien tertunda dong untuk seri, misalnya dia tadinya kemonya untuk seri kelima, berarti tertunda dong seri kelimanya karena obatnya sudah dioplos gitu ya Pak ya?
Iya, harusnya diganti dengan obat yang sama, Bu, untuk dioplos ulang.
Oh, begitu ya Pak.
Kemoterapi tetap berjalan, yang setelah 5 hari beliau kondisinya ada perbaikan atau membaik, tapi tentu obatnya nggak bisa digunakan lagi setelah dioplos, biasanya harus diganti ya. Itu resiko sih Bu biasanya. Kan kita tahu obat kemoterapi mahal sih memang.
Iya, siap Pak. Iya, terima
Seperti
kasih
itu,
Pak.
Mungkin pernah nambahin ya Pak Nafis.
Silakan Bu.
Benar ya. Jadi benar tadi yang disampaikan Pak Nafis. Jadi kita Bu Timer sebagai nursing, jadi kita harus benar-benar mengkaji benar di awal sebelum pasien itu diberikan kemoterapi. Oh, obatnya jenisnya obat-obat apa aja? Obat-obat ini pengaruhnya ke organ mana? Kan Ibu tahu bahwa Ibu udah pelatihan kemoterapi belum ya? Maaf.
Saya bukan perawat kemoterapi, Bu.
Oh ya udah, tapi perhatiannya bagus banget.
Ya.
Jadi memang tadi juga disampaikan oleh Bu Alen bahwa kita sebagai perawat onkologi, terutama yang mendalami kemoterapi, tadi topiknya banyak kemoterapi, memang harus punya sertifikat. Yaitu tadi Bu, jadi kita harus kaji benar apakah pasien tersebut sudah siap untuk dikemoterapi. Dari keadaan umum, dari pemeriksaan fisik, dari fungsi-fungsi sistem dalam tubuh, laboratorium. Jadi jangan sampai, ya itu tadi yang Ibu ceritakan, pasiennya baik, tiba-tiba kok jelek. Nah itu tanda tanya juga buat saya gitu loh. Apakah benar dipersiapkan? Oh, apakah dosisnya sesuai? Jadi banyak kaitannya Bu. Oh, apakah dosisnya pas loh buat pasien pada saat diberikan kok langsung kondisinya jelek. Dan juga dilihat juga efek samping dari obat yang lain. Mungkin itu Bu lebih dikaji lagi. Tapi tadi disampaikan bahwa setiap obat mempunyai efektivitasnya yang berbeda-beda. Jadi tidak bisa disimpulkan juga Bu, oh harus selesai tadi disampaikan 24 jam udah nggak bisa dipakai berapa jam, sesuai dengan obatnya. Nah, kalau memang obatnya itu masih bisa digunakan dan kondisinya belum bagus pasiennya, obat itu dikirim ke farmasi untuk disimpan sesuai dengan penyimpanannya setelah dioplos. Kemudian kita observasi pasiennya dan kalau misalnya membaik, lapor juga ke DPJP-nya apakah bisa dilanjutkan kemoterapi. Gitu Bu. Jadi itu yang harus emang kompleks banget, jangan sampai kita tadi karena obat mahal dan sebagaimana akan mempengaruhi dari bisa juga kerugian pasien, juga kerugian pada rumah sakit. Mungkin itu tambahannya Bu Tumiar.
Oh siap Bu, terima kasih banyak Bu.
Ya, mungkin kita lalu ya raise hand satu lagi nih sepertinya dari waktu diskusi ini ada satu lagi yang bisa kita fasilitasi. Ini ada Sri Mulyani nih raise hand, dari mana ya Sri Mulyani? Silakan. Sri Mulyani.
Sepertinya kemecet dari awal, Bu.
Oh, ya udah nih kayaknya ada di chat, sepertinya juga tidak ada, sudah dijawab oleh Pak Namis dan Bu Alen dengan komprehensif dan jelas bagi peserta. Mudah-mudahan sesi yang kedua ini makin jelas bagi teman-teman nurse sobat Himponi yang pada siang ini tetap stay untuk mengikuti webinar kita pada siang ini, di mana pesertanya masih banyak ya, masih sekitar udah mulai 355. Terima kasih kepada dua narasumber yang sangat istimewa dan luar biasa kami ucapkan, dan juga kepada partisipan yang sangat antusias dan bertanya, bisa bertanya langsung dan juga di chat. Mari kita sama-sama sebelumnya ada sertifikat yang harus disampaikan nih kepada Pak Nafis dan Bu Alen sebagai appreciate dari himpunan kita, himpunan perawat onkologi, untuk kesediaan daripada Bu Alen dan Pak Nafis untuk hadir dan membawa berpartisipasi dalam webinar ini. Mungkin secara simbolis, Bu Rita, masihkah ada?
Ya, Bu Nani siap. Oke. Luar biasa, terima kasih banyak. Habis Bu Alen, luar biasa.
Sama-sama Ibu.
Keren ya. Ternyata masih banyak yang harus kita lakukan ya. Banyak pertanyaan tadi saya senang sekali. Artinya tugas kami di himpunan mesti memberikan lagi nih ya, sangat basic pertanyaannya ya. Nanti mungkin ke depan kita bisa kira. Sekali lagi terima kasih banyak kepada Pak Nafis, Bu Alen. Silakan Mas Rudi, sertifikatnya ditampilkan. Mohon diterima dengan baik.
Terima kasih Bu Rita.
Ya.
Ibu Nani terima kasih dan tim Harmoni semuanya terima kasih.
Ya, ini buat Pak Nafis dan Bu Alen, buat Bu Alen sertifikatnya.
Disuruh matiin.
Ini sudah tertutup.
Sertifikat Bu Alen udah? Bu Alen kemana nih sertifikat? Oh, ini masih Pak Nafis.
Tadi sudah Bu, tapi ketutup nih, saya coba cari lagi.
Tidak.
Terima kasih Mas Rudi.
Lalen ada ya sertifikatnya.
Ada.
Nah, mungkin terima kasih Bu Rita.
Terima kasih Bu Rita, Bu Nani.
Narasumber Bu Alen dan Pak Nafis yang sangat hebat. Jadi memang buat teman-teman nurse sobat Himponi, bahwa memang safety itu paling utama dan paling harus jadi fokus utama dan harus mendarah daging, jadi membudaya. Jadi saya ingat pesan dari pakar patient safety yaitu Dr. Niko Lumenta, bahwa kalau kita ingin menjadi budaya, kita harus merasakan apa yang dirasakan pasien. Ada istilahnya namanya BPIS. Bila pasien itu saya. Nah, tadi banyak sekali yang ditampilkan oleh pembicara hari ini bagaimana dampak kemoterapi terhadap pasien. Memang tadi radiasi ternyata juga sangat banyak Bu dampaknya ya. Cuman mungkin kita gali lagi untuk bagaimana kedepannya dalam memanage daripada pasien-pasien dengan radiasi. Memang kalau kemoterapi memang sudah sampai tingkat RSUD dilakukan, tetapi kalau radiasi memang fokus pada rumah sakit mungkin tipe A dan tipe B. Tapi tadi dengan seperti itu ya menjadi perhatian buat kita untuk kedepannya kita menjadi perhatian terhadap onkologi. Kemudian bagi teman-teman juga yang sampai juga Dr. Niko itu menerbitkan buku yang judulnya Pasien Safety Harga Mati. Nah, itu sudah benar-benar bahwa kita harus mengedepankan safety buat pasien, safety juga buat petugas. Mungkin itu akhir kata yang bisa kami sampaikan pada sesi yang kedua ini. Saya sebagai moderator ada salah kata, ada penyebutan dan sebagainya, mohon maaf. Saya ucapkan salam lagi ya. Salam tangguh, salam sehat, salam caring. Ini Bu Rita paling caring, itu harus caring karena pasien kanker itu harus caringnya paling utama. Mungkin itu saja. Saya akhiri. Wassalamualaikum warahmatullahi wabarakatuh. Saya kembalikan kepada Ibu Vera.
Selamat siang Bu.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam.
Baik. Thank to Nurse Nani Sutarni who has guided us to discuss in the second session. Alhamdulillah, we have finished the last session well and smoothly. I also would say thanks to both of our speakers in the second session, are Mrs. Aleni Dekania and Mr. M. Nafis, who have shared the awesome material to us. Semoga yang sudah didiskusikan pada hari ini, baik pada sesi 1 dan sesi kedua, dapat bermanfaat dan dapat diaplikasikan di institusi masing-masing. Dear Sobat Nurse Himponi, dalam diskusi tadi masih banyak yang belum diketahui oleh kita semua. Kami dari Himponi akan menindaklanjuti dengan perencanaan untuk mengadakan beberapa pelatihan terkait pemberian kemoterapi, pelatihan perawatan pasien kanker dengan radioterapi. Selain itu, sebagai informasi, kami dari Himponi juga akan mengadakan pelatihan basic cancer yang dapat diikuti oleh seluruh perawat yang berminat mendalami tentang keilmuan dan kompetensi tentang onkologi. Untuk seluruh update informasi akan kami informasikan melalui sosial media kami, yaitu di Instagram dengan alamat @dpp_himponi. Please, for all the participants can follow this ID. And our website https://himponi.org. Dear Sobat Nurse Himponi, we finally come to the end of today's agenda. Let us close this webinar by reciting Hamdalah, Alhamdulillahirabbil alamin.
Alhamdulillahirabbil alamin.
Thank you so much for all the speakers who has shared their knowledge and their experience. Thank you for all moderators, all the committees who have prepared the event well. Thank you for all the participants who have joined in our Zoom room and YouTube, who comes from Indonesia, Hong Kong, Sri Lanka, Malaysia, and Bangladesh. Thank you for your attention from this morning until this afternoon. We also want to thank PT B. Brown, who has become our sponsor for this webinar. We apologize if there was mistakes from the start preparation until the end of this event. I am Vera Sulistianingrum. Let me say goodbye. See you in the next webinar. Wassalamualaikum warahmatullahi wabarakatuh. Selamat siang. Have a good day, everyone. See you.
Selamat siang. Terima kasih.
Terima kasih. Terima kasih semua Bu Vera, Pak Rudi, Bu Rita.
Terima kasih.
Terima kasih buat semua tim panitia.
Ya.
Kita nggak usah foto, Bu. Banyak.
Nggak usah, udah banyak sekali, udah banyak fotonya tadi. Terima kasih. Teman-teman, ditunggu ya, nanti ada acara-acara yang mengejutkan lagi dari Himponi. Yang lebih seru.
Terima kasih.
Terima kasih Bu Rita.
Sampai ketemu lagi.
Bu, apakah ada absensi kembali? Terima kasih.
Mas Rudi bisa di
Di end ya, Bu?
Ya, di end aja.
Terima kasih.
Terima kasih.